doctors, healthcare professions. I'm Dr. Marcelo Spinola, allergist and immunologist. I would like to say thank you to the conference committee for to invite me and to say you are very welcome to the second day of the Maternal and Child Health Congress. Now, I would like to invite Dr. Issa Al-Sayed, chairperson, to officially open the pediatrician session and introduce our first speaker.
Sound is okay? So thank you to the second day of the MACH 2. Our first presenter, who would be on a recorded presentation, is Professor Mu'inuddin Sayed from Saudi Arabia. He's the chairman of the Department of Medical Genetics at King Faisal Specialist Hospital and Research Center, and he's a professor of genetics at Al Faisal University in Riyadh with a long experience. He would be talking about metabolic emergencies. I thought it was recorded. Not recorded. It's online. Okay. Dr. Mu'in, are you with us? Sorry, I said it's recorded, but it seems it's online, Zoom presentation. Dr. Mu'in? Dr. Mu'in Sayed, are you with us?
Assalamu alaikum, can you hear me?
Okay. Dr. Mu'in, can you hear us? Can you hear me? Would you please start your presentation? Assalamu alaikum, Dr. Mu'inuddin. Prof, can you hear me? Assalamu alaikum, Dr. Mu'in. Can you hear me?
Maybe you can open your microphone because your chat is open.
Dr. Mu'in, we can't hear you. Can you hear us? There is always
Can you hear me now?
Yes, yes, we can hear you, doctor. But can you put the slides on? Professor Ma'in, can you hear us?
Dr. Ma'in? Yes, I can.
Hello, can you hear me?
Yes, now we can hear you. Go ahead, Prof.
Hello. Can you hear me now? Hello.
Yes, Prof, we can hear you. You can go ahead. But yeah, go ahead, yes. We can see your slides now.
أهلا يا أحمد. دخلت مرتين يا أحمد بس I cannot hear anybody and I cannot turn on the video.
You may start, Prof. We can see your slides and we can hear you. Professor Ma'in, you can start. If you can you hear me? We can see your slides.
Assalamu alaikum wa rahmatullahi wa barakatuh. It seems like that you can hear me, but apparently I cannot hear you and I cannot turn on my video. So first of all, I would like to thank the organizing committee for inviting me to present in this esteemed conference. And specific thanks to Dr. Suhail Shabib for facilitating this invitation. So I'm going to talk about metabolic emergencies inside And I thought it would be nice to give you an insight into our King Faisal Specialist Hospital metabolic and genetic cohort of patients, because I think it broadly represents the region as it's being the main center for inborn errors of metabolism for a long period of time. So let me start with this patient who was referred to me from our ENT colleagues. And this patient was referred because she had profound sensory neural deafness, and the ENT physicians thought that she had some dysmorphic features, and specifically prominent, their notes included that she had prominent tip of the nose. So when we examined this patient more carefully, we found that the patient, in addition to the sensory neural hearing loss, the patient also had smaller teeth, which were misaligned, and there was an increased space between the teeth, as you can see. Further examination of her ears showed that she had dysplastic low-set right ear and bilateral asymmetrical microtia, type 1. So, okay, I guess now I can, you guys can probably see me as I received the notification. Okay, so CT of the temporal bones that we have done for this patient revealed that she had asymmetrical tympanic cavities, and on the right side there was no cochlear system or vestibular system that was visualized. Whereas on the left side, she had this rudimentary cystic vestibulum that was recognized. So when we took further the family history, it turns out that the family comes from an area in the real south of the Kingdom of Saudi Arabia, just at the borders of the Yemen. And it's a mountainous area. And we decided, as people who work in genetics and metabolic diseases, when we see such patients, we think maybe there could be some more patients. So we decided, in collaboration with the family, to visit their village. And as soon as we entered the village, we saw a school right on the top of the mountain. It's kind of a hilly area, and you can actually see Yemen from these hills. So when we asked the father of this patient, what is this school about? He said that this is the school for the deaf, and there are more than 50 children that are studying in this school, to our astonishment. So we went and took a more broader family history, and what we saw that there are multiple members in the family, as you can see, who are affected with the similar condition that our patient has with sensory neural deafness, in addition to abnormalities of the ear. So cutting the story short, we got samples from family members and we mapped the gene, and it turns out to be a fibroblast growth factor 3 gene, and this was published in one of the journals as a syndromic congenital sensory neural deafness, microtia and microodontia, resulting from a novel mutation in fibroblast growth factor gene. So the reason why I mention this is inborn errors of metabolism and genetic disorders in general are quite common in our region because of the homogeneity of the genetic pool and because of the the tribal structure and the consanguinity, as you know. So coming back to our metabolic disorders, just to refresh the memory of the junior staff and the residents who might be attending this meeting, a majority of inborn errors of metabolism, they revolve around a metabolic pathway where there is a substrate and there is a product. And this metabolic pathway is facilitated by a reaction that is facilitated by an enzyme and a cofactor. So if there is a deficiency of the enzyme or the cofactor, in some cases, this will result in the disruption of this metabolic pathway. And that is going to result in the deficiency of the product or the later products of this particular pathway, or the accumulation of the substrate or the precursors to the substrate. And sometimes alternate pathways are activated in the absence or in the when the main metabolic pathway is diminished. So on the same line, if we look at some of the inborn errors of metabolism in Saudi Arabia, or maybe in the broader Gulf, and compare their incidence and prevalence with other places in the world, you can see that a lot of the common inborn errors of metabolism are anywhere between 10 to 33 times higher when you compare it, for example, with USA data. So these figures that you see from Saudi Arabia, they are coming from various publications and as well as newborn screening that's going on for many years in Saudi Arabia. We also know that we have founder mutations for a large number of inborn errors of metabolism and metabolic disorders and genetic disorders that we have published in the past. And these founder mutations are also one of the main contributing factors to why these diseases are seen more commonly in our region. So coming to the core subject of metabolic emergencies. Now, I thought that, the best way to present this is to present it in the clinical scenarios instead of, boring you or on a Friday morning with complex metabolic pathways. So basically, metabolic diagnosis is considered in at least 5 or 6 different presentations. So there is the catastrophic neonatal presentation, biochemical disturbances, which are often characterized by recurrent biochemical disturbances, liver disease or dysfunction, which is sometimes acute, but it can be also chronic, neurological symptoms with acute events as well as chronic events, myopathy, cardiomyopathy, and least important in an emergency presentation is signs of a storage disease, which is typically something that builds up chronically or subacutely over a period of time and rarely presents as an emergency. So I think many of us as pediatricians or neonatologists who work in NICU units or nursery must have come across a metabolic patient or a newborn with a metabolic disease that presented with a neonatal catastrophe. Often these babies are born normal and then they are discharged, and few days later they present to the emergency room, maybe a day or 2 or sometimes 3 days later. And in less common scenarios, they may get sick soon after birth, and they present typically with feeding problems, intolerance of feeding, vomiting, lethargy, which sometimes proceeds to encephalopathy and coma, altered muscle tone, hyperreflexia, and in severe toxic disorders, they may present with seizures. And often because of the metabolic acidosis, they present with Kussmaul respiration and tachypnea. And basically they, the best way of describing them is somebody who is septic appearing. And there are a number of inborn errors of metabolism in our region and broadly that present with a neonatal catastrophe. On top of it, organic acidurias like propionic acidemia, methylmalonic acidemia, branch-chain amino acid defects like maple syrup urine disease, Arginino Saxonic aciduria, which is a urea cycle disorder, citrullinemia, a urea cycle disorder, and primary lactic acidosis, which presents with very severe metabolic acidosis, as well as glutaric aciduria type 2. Now, some of you may be familiar with this kind of a clinical presentation of a a baby who is few days old, who goes home and then comes back to you in a state of severe lethargy and encephalopathy. So this is a child with methylmalonic acidemia. And I know that, some of these disorders are in the newborn screening in many different places in the Gulf region. And typically the technology that is used, and you may have heard about it, commonly known as tandem MSMS. But what it is, it's basically measurement of acyl carnitines. And in methylmalonic acidemia, it's propionyl carnitine C3 that increases, and it can be picked up in a dried blood spot. So this particular child had a very high propionyl carnitine, and then when you do urine analysis, you find elevation of methylmalonic acid and other metabolites, confirming the diagnosis of methylmalonic acidemia. Now, these children also present with CNS disease, as you saw with encephalopathy, and typically they will have increased signal intensity in the basal ganglia, and in this particular condition in the globus pallidus and the putamen, what looks like a double mustache sign, as it is called in the MRI finding. This is another child who has actually a urea cycle disorder common in our region called Arginino Saxonic aciduria. And these kids, they present with a little bit earlier on the second day of life after being fed normal protein, or they are fed breast milk or normal formula, and they will present with acute encephalopathy because of the severe hyperammonemia. And they will present with respiratory alkalosis instead of metabolic acidosis, because the ammonia drives the breathing in these patients. And the urea cycle, there is no accumulation of acids. And here again, MSMS, which is a technique that was developed originally at King Faisal Specialist Hospital, is showing in this particular patient an increase in the peak for Arginino Saxonic acid, indicating that this child has Arginino Saxonic acid urea, which is one of the most common urea cycle metabolic emergencies that we see in this region. Moving on to biochemical disturbances. Now, I think this is something that you see often in the emergency presentation of inborn errors of metabolism, and it evolves around metabolic acidosis with increased anion gap. So it's important to realize that inborn errors of metabolism will almost always have a high anion gap metabolic acidosis because of the accumulation of the abnormal organic acids. Hyperammonemia, obviously, and recurrent hypoglycemia. And I think what gives away the diagnosis in these patients is that these are presenting in a intermittent way with acute periods of biochemical decompensation. Now, a number of inborn errors of metabolism in our region present in this way. Majority of the neonatal catastrophe conditions can also present with biochemical disturbances. So organic acidureas like propionic acidemia, methylmalonic acidemia, presenting with severe metabolic acidosis, urea cycle disorders presenting with hyperammonemia, and then conditions that are in the gluconeogenesis pathway or in alternate energy, which is the formation of ketone bodies like fatty acid oxidation defects. They will present typically with hypoglycemia. And in fatty acid oxidation defect, the hypoglycemia is associated with no ketosis or very mild ketosis, which also gives a hint towards the diagnosis. Mitochondrial myopathies also presenting with recurrent episodes of encephalopathy and lactic acidosis, which I will show in a minute. Liver disease or dysfunction commonly presents in a subacute way, but they can present with emergency presentation with acute toxic liver injury or liver failure. typically you will have hepatomegaly, you will have conjugated or unconjugated hyperbilirubinemia, and also importantly, the coagulopathy is often much more severe than the clinical presentation of the liver disease. And this is also a clue to the diagnosis of these conditions, because the metabolites are toxic to the liver and they will affect the synthetic pathway of the liver often very quickly. And these liver inborn errors of metabolism can also present with hypoglycemia and hyperammonemia. So some of these diseases that present with the liver phenotype are tyrosinemia type 1, presenting with to the emergency room with severe hepatomegaly, ascites, and signs of acute liver or liver failure. Galactosemia, which some of you must be familiar with, can present with liver dysfunction, and importantly with E. coli-like sepsis around, or E. coli sepsis around 1 month of age. Rey-like syndrome is something that we see with energy disorders like fatty acid oxidation defect, like VLCAD, which is the most common inborn error of metabolism, fatty acid oxidation defect that we see in this region. Carnitine, acyl carnitine translocase deficiency, and rarely we see primary carnitine deficiency. This is a baby with galactosemia who presented at around 1 month of age with hepatomegaly, with splenomegaly, and with E. coli sepsis. In the emergency presentation, it's important to realize that acute neurological symptoms can also be present, like encephalopathies, which I was showing you, with organic acidureas, as well as urea cycle disorders, but also with acute onset of dystonia, which is seen in some inborn errors of metabolism that I will show in a minute. And some of the inborn errors of metabolism can present with stroke or stroke-like episodes like MELAS, and as well as organic acidureas like methylmalonic acidemia, propionic acidemia, and glutaric aciduria. So these are just a list of some of the conditions that can present with the neurological phenotype. And I will just highlight some of them, because they are, things that we see in our region, and it's very important to recognize them early. So this is one of the inborn errors of metabolism called Biotin thymine responsive basal ganglia disease. And it's very important to recognize this condition. One of my patients presented at 10 years of age with the first episode of a metabolic stroke secondary to this disorder. And why is it important to recognize this? Because treating this condition with biotin and thymine results in a rapid improvement and actually is life-saving in these patients. So what they show on the MRI, they show so they present with an acute or subacute encephalopathy with confusion, seizures, dysarthria, and dystonia. And this is usually followed by a history of febrile illness. And in this particular MRI from one of the patients, you can see the substantia nigra hyperintensity signals here, and then involvement of the basal ganglia, involvement of the parietal and the frontal lobes, and in the spinal cord. I don't know if you can see this, but there is hyperintense T2 hyperintense signals in the spinal cord. A treatable disorder, but it needs to be recognized very early and typically presents with emergency presentation with acute or subacute onset of encephalopathy. This is a relatively new disease that we discovered a few years ago, and among 20 plus patients that are described, 99% of the patients come from the Arabian Peninsula. And these patients will come to the emergency room with a severe lactic acidosis with encephalopathy and dystonia. And on an MRI, you will see basal ganglia lesions with especially the posterior aspect of the putamina is affected. The gene was identified for this condition, and this was published, and it is an SLC25A42 associated mitochondrial encephalomyopathy. So patients who present with acute encephalopathy, acute stroke, dystonia-like features with severe lactic acidosis, these are some of the conditions that need to be considered. Another disease that can present in an emergency fashion is glutaric aciduria type 1. These children are often okay until about 6-7 months of age. Then following an upper respiratory tract infection, they will present with onset of dystonia, spasticity, and developmental cessation. And the first presentation can be to the pediatrician or to the ER visit. This is a child with who looks unhappy, looks miserable, with failure to thrive, with alopecia, with skin lesions, and this is a condition called Biotinidase Deficiency. And they, in cases that are not where there is late presentation, they may present to the emergency room with this state of encephalopathy and looks like, acute or chronic nutritional deficiency. And with treatment with biotin, they typically improve rapidly with regrowth of the hair, and they start looking more bright, and their skin lesions start to disappear. The last phenotype that is important to keep in mind as an emergency presentation of inborn error of metabolism is the myopathy or cardiomyopathy. And this can present in an acute way, or it can present subacutely or in a chronic presentation. The acute presentation is important to recognize, especially the cardiomyopathy, as well as the myoglobinuria, and sudden onset of muscle weakness. And typically we see this in disorders that are related to energy metabolism, like fatty acid oxidation defects and mitochondrial disorders. And for the cardiomyopathy, obviously, you are probably familiar with Pompe disease or glycogen storage type 2. This is a baby that presented with significant hypotonia after birth and some level of lethargy and encephalopathy. And she has one of these energy defects called carnitine acylcarnitine translocase deficiency. In this category, it's important to recognize very long chain acyl coenzyme A dehydrogenase, because they present with acute elevation of CK with myoglobinuria in some patients. They will present with severe myopathy and Ray-like syndrome. And again, acylcarnitine profile is very helpful in the diagnosis of this condition. It will show elevation of the long chain fatty acids, as you can see in this acylcarnitine profile. So the final few points that I would like to drive home is, in addition to these more common disorders that I've mentioned and these presentations, there are few diseases that we see in our region that are important to mention. And this includes pyroglutamic aciduria that presents with a severe metabolic acidosis, ethyl malonic aciduria, also another condition that presents with spasticity and very peculiar purpuric rash on the skin, which I will show in a minute. Malonic aciduria can present with severe acute onset of cardiomyopathy and encephalopathy. Mitochondrial depletion syndrome is a group of disorders that presents with acute or subacute onset of liver failure. Another disease that we have described recently is Migdal, which is a condition that presents with Ley-like syndrome, encephalopathy, dystonia, and hepatomegaly. So just to show you, some of these patients will present to the emergency with a state of spasticity, spasticity, dystonia, and when you sort of look carefully at their skin, you will find these kind of linear purpuric erythematous rashes that really gives away to the diagnosis of ethyl malonic aciduria. So in terms of metabolic testing, it's really not that complicated. People think of inborn errors of metabolism as highly specialized, difficult to diagnose, but actually there are things that you can, the basic labs that give you hint towards the diagnosis. So blood gases, are important in these conditions because they present with acidosis, or in the case of urea cycle disorder after birth with respiratory alkalosis. Almost all inborn errors of metabolism with acidosis present with high anion gap metabolic acidosis. Liver dysfunction is very important. Also, liver function, because as I said,
Professor
elevation
Mu'in,
of
2 minutes,
PTCT and
please.
coagulopathy in the presence of not so severe severe liver disease often gives way to the diagnosis of inborn errors of metabolism. Recurrent hypoglycemia with no ketones or with hypoketotic state also is typical of inborn errors of metabolism, specifically fatty acid oxidation defects. Now, of course, there is more advanced metabolic tests that can be done in an emergency situation, like lactate, ammonia, creatine kinase. So severe hyperammonemia in the presence of respiratory alkalosis is usually a urea cycle disorder until proven otherwise. So, basic knowledge of these metabolic diseases often helps in categorizing these diseases when they present in the emergency into a more specific category.
Professor
like urea cycle
Mu'in, would you please
disorder,
wrap up?
like organic aciduria,
1 minute.
like neurological disease, mitochondrial disease, and so on and so forth. I think most importantly, it's extremely important because these patients often die because of a severe metabolic crisis. It's very important in an emergency situation to save samples from these patients, whether it is serum, plasma, urine, as well as now obviously dried blood spot, which can be used for a lot of metabolic testing as well as DNA analysis. So the founder mutations, as I've just mentioned earlier, are common in this region, and we see them, and therefore, the presentation in the emergency room is common in our countries. So just to summarize a few words, inborn errors of metabolism are common in the Gulf region. ER presentation is commonly seen. The most important step really in initiating a diagnostic evaluation is to have a high index of suspicion, and diagnosis does not really require extensive knowledge of biochemical pathways or individual metabolic diseases. Our colleagues in the ER should, or in the NICU or in the PICU, should have a working knowledge of when to suspect an inborn error of metabolism, very severe metabolic acidosis, unexplained, high anion gap, elevated ammonia, acute onset of neurological symptoms, acute onset of myopathy, cardiomyopathy, myoglobinuria. These are all many different presentations that should, make us suspect an inborn error of metabolism. And I think it's important also to be familiar with the emergency management and metabolic medications that are used in such emergencies, because they can be life-saving. So I think I'm going to stop here, and I thank you for listening. And again, thanks to Dr. Suhail Shabib for inviting me. And there was a bit of glitch in the beginning, but hopefully, everything went smooth. Thank you. I don't know if there's time for some question. I'll be happy to take it if I can hear your questions.
Yeah, thank you very much, Professor Mu'in. We are tight on time, but there's one quick question regarding from Ghilan Al-Khatir, I think. I hope I pronounced his name right. He's asking about the increased risk of E. coli, sepsis, and UTI in galactosemia. Why is that? I don't think Professor Mu'in can hear me, so we'll go to the next speaker.
So there is a question here, why E. coli happens with galactosemia? That's a question from Dr. Khatir. We really do not know why that happens. The galactosemia apparently, the sugar abnormality that takes place in galactosemia somehow attracts E. coli. But exact mechanism is a great question, is really not known.
Thank you, Professor Mu'in. We have to go to our next speaker, Dr. Marcella Espinola. Dr. Marcella is a consultant in pediatric allergy and immunology. She was a lecturer at Federal University of Pernambuco. I hope I am pronouncing right.
That's right.
She's my first colleague from beautiful Brazil, and she's a very nice doctor and excellent consultant. So Dr. Marcella currently is a consultant at Royal Hospital for Women and Children, and she will be speaking about most common childhood allergic diseases. Please.
Okay, good morning again. Good morning, everyone, doctors, colleagues, and professional healthcare. Today, you talk about most common childhood allergic disease. How can I pass this one? Okay, this is our agenda. I can pass on for the control. Okay, allergic disease is considered the most common chronic disease in childhood and results from the interaction between genetic predisposition and exposure to allergy and environmental irritants. It's a chronic disease, okay? The inflammatory process is present even outside the periods of exacerbation, which is the basis for the importance and maintenance of the treatment. According to the exact study on the prevalence of asthma, up to 20% of the school-age pediatrician population has some allergic symptoms. Research current out of the situation of the clinical control, for example, had their symptoms and nocturnal walkway, that is, that were not under control of their disease. I can pass only this one. Some manifestations are caused by the production of specific IgE for allergen present in the environment and such mighty proteins, food, insect, pollens, and mold. The diagnosis is made primarily by detailed clinical history and physical examination. It's really important to understand and remember the innate immunity system and work to integrate stimulation for environmental triggers and release the information into adaptive immune system. Dendritic cells in tissues responding to microbiome models, model associated with lesions or allons, with a change in the phenotype that determined the T cells response function generated by presentation of the antigens. The T-cell macrophages will respond of environmental stimulus, releasing cytokines that can start the immune response to antigen derived from these tissues. The dendritic cells, for example, in peripheral blood of patients with food allergy have an heteroid phenotype compared to healthy controls, leading to increase to the production for pro-inflammatory cytokines in response to allergic symptoms. Such responses are probably linked to yes. Sorry, there's a lot of delay with the slides. The responses are probably linked to styling by FC receptor in the dendritic cells. Most common allergy disease, it's asthma, allergic rhinitis, atopic dermatitis, insect bite, and food allergy. First one, asthma. It's made from the, my God. Can you help me here, please? Because I can't pass in this one. Okay, asthma, estimated from the World Health Organization. Asthma affected 230 million people worldwide. Responsible for 40 cases of hospitalization, asthma is defined as a bronchial obstruction usually caused by inflammatory process. Asthma can be allergic or non-allergic. The most common in children is allergic asthma. Despite physiopathology, we have genes predisposing to allergen things that increased TH2 expression, stimulating some interleukin activity B cells and production some IgE antibody. In mast cells in contact with allergen, it started the acute crisis. For example, hyperactivity responsive bronchospasms, edema, and air obstruction, and in chronic disease, chronic inflammatory, and hemodynamic tissues. Okay, it's really important you understand if you have allergic asthma or not. Não está passando direito os slides. Não está passando. Sorry, back again. When you talk about asthma, it's really important you understand the allergic asthma, if it's have or not allergic asthma. If you have IgE positive for allergy molecules associated with respiratory allergy, plus the rise of IgE specific for respiratory virus, after asthma attack, we have allergic asthma. IgE positive for allergy molecules and associated with respiratory allergy, plus rise of IgE specific for respiratory virus. After asthma attack, we have probably allergen and virus triggered after asthma attack. But if you have IgE negative for allergy molecules associated with respiratory allergy, plus rise of IgE specific for respiratory virus after asthma attack, you have virus-triggered asthma. It's really important for you define our treatment and additional treatment options. For our additional treatment option, according to asthma phenotype, for example, you have allergic asthma IgE mediate with this characteristic, and you can add anti-IgE biologic. If you have eosinophilic asthma with this characteristic, you can add anti-interleucin 5 biologic. Neutrophilic asthma, considered add microlidial antibody, and airways multimuscle hypertrophy, you consider broncho thermoplasty. For treatment, it's really interesting you follow this step. Intermittent asthma, for example, use only treatment for acute crisis. From step 2, you can use low dose inhalant corticosteroid. Step 3, plus long-acting beta-2 agonist. Step 4, medium dose. Step 5, high dose. And step 6, high dose plus oral corticosteroid. And lab 2. It's really interesting you understand. You can consider omalizumab for step 5 and 6. And from step 2 to 4, you can consider immunotherapy specific by patients. It's really important to this highlight. You understand, in this age, you can't use omalizumab, okay? The last 2 years had a proliferation of quality of life in asthma. Asthma guidelines were... Eu não estou conseguindo usar no computador. The computer can't working. Eu estou com controle. Não está funcionando. Don't working, sorry. Okay, the last 2 years held profiled high quality asthma. Asthma guidelines were up to date, and new insights into pharmacology management of patients include biologic immunotherapy specific for patients. The main is individual treatment, include biologic and immunotherapy consecutive. No working. Test this one. Okay. Allergy rhinitis, it's not contagious. The symptoms are these attacks, clear one nose, each nose, sometimes together each eyes, ears, or throat, and nasal stiffness. A child with allergic parents will have 15 to 70% increased chance to develop a respiratory disease. The incidence progresses until adolescence, a stage of life in which can affect up to 25% of population. The most common symptoms is this, congestion, and run nose. But it can be itch and sonorous coughs and postnasal drips, red, itch, and water eyes, and sometimes can come in the ears, itch ears, and buzzing sound. For diagnosis, it's interesting to exclude the other causes for symptoms, high-need symptoms. Start the physical examination as a cavity, skin prick test, cutaneous test, and IgE-specific itch allergens, or IgE total and serum. If positive, you have allergic rhinitis. If positive but don't have clinical historical reaction, you can make a nasal provocation test at hospital, please. If positive, local allergy rhinitis. If negative, no allergy rhinitis. For classification, you have rhinitis intermittent and persistent. Intermittent can be mild or moderate to severe. Persistent, mild to moderate to severe. It's really interesting for the classification. For classification, the treatment used in patients. On the level 1, you can use antihistaminic, sometimes leukotriene antagonist. The level 2, intranasal steroids. Level 3, intranasal steroids plus azilastine. 4, oral steroids, short course. And 5, if everything not happens, you can send the specialist for start immunotherapy specific. For treatment, it's good you follow this step. For rhinite mild intermittent, you use medicine for acute crisis. From this one, you can use all this medicine. And this highlights and this talk for the immunotherapy specific each patient. When you talk about skin allergy, atopic dermatitis is the most common in childhood. Around 60% of the cases occur in the first year of life, with gradual improvement towards the end of childhood. Its characteristics characterized by an inflammatory process of the skin with alternating period with improvement and worsening. It's not contagious, it has a genetic characters, and it often processes asthma and rhinitis. About prevalence, we have in green area, the 0 to 5% of the prevalence. In light green area, it's my country and my region, you have the 5 to 10% of prevalence. But in our area, you have 10 to 20% prevalence, depend each country. Some patients ask me, doctor, atopic dermatitis have any correlation with genetic? The answer is chemical colored proteins break down to the corneal stomos. Normal skin has low level of the protease. And allergic eczema, patients with allergic eczema, for example, changing the gene for which production high level of these proteases. Leads to premature breakdown of corneal stomos, and the answer is yes. Most common areas compromised in babies is face, elbow, and knee. When you compare within the older children, you have under eyes, crease of elbows, wrists, and the outer surface of the arms, leg. Above 12 years old, you can most common area compromise is popliteal fossa and cubital fossa as well. The symptoms include itchings, small bumpings, skin dry, sensitive and cracked dry skin, and red patches. The treatment, you can include everything. Warm shower, for example, moisturize, wear soft clothes, eat healthy, humidifier, and some corticosteroids, topical or oral steroids. For treatment, it's good to follow this step. Basic treatment include education programs, emollients, sometimes antihistaminic and no sedating. Mind, you can use topical steroids. It depends on the area, topical calcineurin inhibition. Moderate setting antihistaminic, sometimes UV therapy. And severe case, hospitalization, unfortunately, systemic immunosuppression, and cephalosporin. Insect bite. What is it? Allergy of the insect usually occurs after bites. The body reaction with redness, itches, swelling. Depending on the insect and the intensity of the allergy, anaphylaxis can occur also, making the case more severe. You need to pay attention about bees, ants, and wasps are the main cause of the big and severe reaction. It's really important you understand and check the allergic reaction, the local allergic reaction, because depending on the insect, you have a big, mild, or severe reaction. Patients with insect setting or biting, you need to talk about the clinical history, history about some allergens, depending on the physical examinations. If you have some systemic symptoms, it's really, really important you immediately emergency care referral. Because anaphylaxis can be effects on the body, is dizziness, itchy mouth, coughs, nasal congestions, wheezing, nauseous, vomitus, itchings, swelling in the hand, feet, eye swelling too. It's really important you understand this for not come through this step. Anaphylactic shock. What is it? Serious life-threatening allergy reaction that is repeated in action and may cause death. The causes include insect bite, foods, and medication. Treatment include an injection of epinephrine, intramuscular, the famous epinephrine EpiPen, and the vasolateral muscle of tight. Finally, food allergy. The prevalence shows around 6 to 8% of children up to 2 years old suffer some type of food allergy. More than 170 foods are considered potential allergenic, but it's really interesting you focus on the 8 major food allergy. First is milk, second is egg, third is soy. The reaction can be mild, with simple itch of the lips, or to more serious, including involvement of several organs and potential risk of the death. The immune mechanism of food allergy is responsible for hypersensitivity. It can be mediated by IgE, immunoglobulin E, cells, or mixed reaction, IgE mediate and cells. As a result, it's a lot of different symptoms and organs appeared. For example, on the skin, urticaria, angioedema, some atopic dermatitis, and the other ones, eczema and the other ones. Gastrointestinal, diarrhea, vomitus, abdominal cramps, and etc. Respiratory, runners, coughs, and bronchitis, asthma. In anaphylactic reaction, hypertension, and the other severe involvement. About food additives are represented by antioxidants, flavors, food colors, mainly tartazines, the color yellow, okay? Preservatives, thickness, and among others. You can know with skin prick test, HAS test, and monocap, it's essential for the diagnosis and monitoring of the allergy. It's very important to follow the follow-up with allergists, gastroenterologists, and dietists to learn about the main allergy present in food. Other things really important, the family understand, need to read all label, all food. Allergic test basics is skin prick test, prick to prick, patch test, IG total, HAS test, and monocap and microarray. A skin prick test is a mediated allergic reaction and results to measures specify IgEs of specialized antigens. It's a little invasive, and when performance quality, it has a good accuracy, around 98-99%. The procedure is educational because you have all the allergy you can be to be visualized on the skin. The prick to prick, that means it's the same to prick test, but the performance consists in puncture with lancet on the food after you perform the puncture on the patient's skin. The disadvantages are no standardizations and risk of hyperactivity. About patch test. Consists the application of allergen. Use some method as traditional for contact test, the allergic contact dermatitis. The appreciation of patch tests is still discussed because you don't have ideal concentration, you don't have ideal time for application, It's not most common in our practical clinical for kids. Hydroallergenic sorbent test, the famous HAST test. The presence of the IgE antibody indicates sensitization. Atopic dermatitis and manifestation possible triggered by IgE antibodies, such as anaphylaxis by insect, reaction to food, and eventually to medication you can show in this rest. The IgE determination performance by immunoassay, ELISA, IgE total determination helps to the differential diagnosis. It's the first case. Other approaches to diagnose IgE-mediated allergic sensitization is immunocap, ELISA, immunoblot, and microarray. Microarray in the last 10 years, a technology capable of production miniature of DNA or protein sequence has made it possible to analyze hundreds of simple simultaneous. It's really interesting because the amount of blood needed for the screen is only of the great differential of the microarray. The sensitivity is the method is compared to HAS, ELISA, and immunoblotting. Finally, the importance of the treatment of allergic disease line is the fact it is a chronic disease, for which there is still no cure. The main objective, therefore, to improve the patient's quality of life by reducing the exacerbation, hospitalization, and of course, mortality. If this is possible to allergic disease, I see one more optimism about the therapeutic possibilities. And in conclusion, all cases it's possible to obtain successful treatment and follow-up with a specialist, since in some more severe and intensive cases, it can be difficult to live with the allergic disease, disturb the child's sleep and performance. Allergic chronic disease, despite not having cure, can be partly or totally controlled with the use of the medications and appropriate immunotherapy. The earlier the diagnosis, the greater the chance of controlling the disease. But the most important to understand how the treatment should be directed to the one that provides the greatest benefit to the patients with lower costs and better adherence. Thank you.
Thank you very much, Dr. Marcella, for this excellent review. I don't have any questions on Zoom. Please write your questions and send them. If anyone in the audience have questions, I'll start. As a general pediatrician or family physician, what type of patients, when should I refer cases to you? What type of patients?
Okay, when you start the treatment, basic treatment, but the symptoms continue, no resolution with the simple treatment, you can send me. The most important things now is the specific treatment. The main is individual treatment. You check the patients, check that some skin prick test, for example, detail of the case, and start the treatment specific each patient with immunotherapy specific, allergic immunotherapy specific. The immunotherapy can be for subinjection or oral drops. It's minimal 2 years, but it's really interesting for change the disease way. Any questions?
Good lecture, Dr. Marcella.
Thank you.
I would like to ask, at what age do you do the skin prick test?
Okay, you can start from 3 months age, because it's important you understand the immunologic cell is different from the other cells, no? B cells, T cells, natural killer cells coming before 2 months. For example, when have a SCID, severe combined immunodeficiency, primary, you can discover, make the diagnosis with 2 months. It's different than the other cells, can be maybe after 1 year old. But immuno cells, you can check from 3 months. But of course, you can't use the arms, you use the back, because baby don't have sufficient area for make the skin prick test.
Do you apply a numbing cream before you do it? Or-
Yes, you can
Yes.
apply in the Royal Hospital, you can send me, no problem.
Okay, thank you.
Thank you.
Dr. Marcella, what's your advice regarding pediatricians doing the RAS test? Do you recommend doing it?
Okay.
How to interpret it, especially when you have multiple response to many things, and then some of us would go and restrict, for example, the food, the diet of the child based on the RAS test.
Okay, the RAS test is most common because sometimes the hospital don't have skin prick test available, okay? But if you don't have a skin prick test available, you can start with RAS test. But RAS test, the accuracy is 45 to 50%, depending on the age. Up to 5 years old, it's good. But before this one, sometimes don't appear nothing. When you have a lot of allergy about this, you need to check, because sometimes the result is not true. Appear for us for class, 0 class to 6 class. Up to 3, from the class 3 to 6, we consider the test positive.
Still, we have a minute more. So, cow's milk protein allergy in young infants. Is there a role for you as allergy immunology for testing?
Yes, you can send it. You can do
From
this
what
one.
age?
From 3 months to 100.
and usually you do the skin prick test?
Yes,
Is it?
you
Yeah.
can do this. Okay.
Okay. No, any questions? Okay. Thanks a lot, Dr. Marcella.
doctor.
If you want to present the next
okay.
patient, yeah.
Okay. Our next speaker, Dr. Paulo Espinola, plastic surgery consultant. He has over 70 years of experience in the field of the plastic surgery, member of the Brazilian Society of Plastic Surgery and the American Society of Plastic Surgery. He's from Brazil, professional with extensive experience in reconstruction and aesthetic surgery. Currently worked as the head of cosmetology and plastic department at Royal Hospital for Women and Children.
Good morning, everyone. First of all, I have to thank you, the committee, the organizing committee, for inviting me, and say thank you to our members here in the stage. Can we start to put there, please? So first of all, it's a little bit weird to have one plastic surgeon in a meeting with a pediatrician. So what I'm doing here, right? So actually, I planned first to speak about plastic surgery in children, and but I add the adolescents as well, just to show more about what we can do in plastic surgery in this age. Please, first of all, be careful with the photos because there's the patient privacy, okay? I have to start speaking about the origins. From the Greek, plastic comes from plastikos, that means moldable, to build up or to take a form. And as you know, plastic surgery has a dichotomization between aesthetic and reconstructive. But we can split the plastic surgery a little bit more. So we have some subspecialties. That means you can see aesthetic surgery, burn surgery, craniofacial, hand microsurgery, and pediatric plastic surgery. That is our main target today. In the pediatric plastic surgery, as a definition, it's that surgery performed on children. The procedure are most often performed as a reconstructive than a cosmetic. But in children, we have to remember that even the reconstructive can have a kind of aesthetic objective means, okay? So it's important that we are mixing this middle. So again, we have the dichotomization in the pediatric plastic surgery that we can see the reconstructive and aesthetic. In reconstructive, we have many areas, many kind of diagnoses and patients that we can see. Mainly, we can see the cleft lip and cleft palate, syndactyly, polydactyly in hands or even in feet, plagiocephaly, craniosynostosis, microtia and anotia. What it is? It's not hypospadia, congenital nevi, hemangiomas, it's more common, and burn. In aesthetic, mainly we have these three: proeminent ears, gynecomastia, and breast hypertrophy in teenagers. And then we reconstruct, we have to start, of course, and by cleft lip, cleft palate. I will not make you like to know about surgical techniques or to show so many details about each area. So, of course, I will speak about all of them, but to understand how to recognize and what to do after this one. So cleft lip and cleft palate, it's a congenital deformity in the upper lip in one or both sides, and in embryogenesis speaking, start between the 4th or the 12th week of pregnancy. The incidence is between 1 in 650 a birth, okay? It's important to understand that is a genetical disorder or can have one environment origin, like, for example, some drugs, alcohol, smoke, some lack of minerals and vitamins as well, some hormonal change, radiation, or even infection in the first trimester of pregnancy can cause cleft lip or cleft palate, or both together. As a clinical presentation about cleft lip, we can see unilateral or bilateral, okay? And cleft palate, of course, can have only the palate. But we can see a mix of clinical presentation with the cleft lip and the cleft palate together. So this one we can see unilateral and a bilateral cleft lip and palate. Just to understand a little bit, can we put bigger, please, and the screen? Can you zoom in? Zoom in? Okay. There. Zoom in. You know what I mean? Because it's too far. Yes, thank you. So this is a bilateral cleft lip and palate, preoperative, immediately after the surgery, after 2 months, and after 3 years. We can see a very good functional and aesthetical result. This is only a cleft palate that's made, of course, we will not speak about techniques here, but it's a closure by layers in the midline. Okay. So, and here we have some case from a cleft lip and cleft palate, before and after. But we have to understand that the treatment for cleft lip and palate, it's not only made by the plastic surgeon, okay? We need to have a team. It's a multidisciplinary treatment. So that start from the radiologist during the pregnancy, that they can detect sometimes if the patient has some sign of cleft lip or cleft palate. The OB-GYN as well, because they will see the first person to see the baby, of course. The pediatrician is the most important because they will follow the patients even after the surgery, they will follow the patient for a long time. Speech therapy, ENT, dentists, and most important, psychologists, not only with the kid, but the parents and relatives is very important as well. The other common disease is the congenital nevus. It's a benign tumor, as we know, but there is a risk to be a melanoma, especially the bigger one. The giant lesions have much more risk, 10 times more risk than the small lesions. In the small lesions, we have around 0.7%, while in the giant lesions, we have around 60% the chance to become malignant. So that's why this patient must be followed very close, or depends to be treated surgically speaking. Unfortunately, some doctors, they are trying some treatments, some non-surgical treatments, and unfortunately still very controversial due to the risk of malignance. So, as a personal opinion, if there is a risk, it's better to remove. The treatment, the surgical treatment, we can perform, or by, of course, if this is a giant one, we can do a partial excision. That means we can do every 2 or 3 months excision inside the lesion to reduce this size, and then, if it's possible, to remove completely. The other option is to use a tissue expander. That depends in the area and depends in the size. We can use expander, and they will expand the skin and tissues until to be able to cover all the defects created by the incision. Okay, so there is 2 examples of partial excision. In the first image, we can see space around an interval between the sessions around 3 to 4 months. Okay. One of the most common tumor, benign tumor, of course, in the skin in children is the hemangiomas. The hemangiomas are benign tumors which arise from the proliferation of endothelial cells surrounding blood-filled cavities. Okay. Sorry. Okay. And the most important is to understand the classification. There is one important classification from the International Society for Study of Vascular Anomaly. Even there is a QR code if you want to download the full classification, because it includes adult and children. Okay. You can get from this QR code. But the most important for us today is about the infantile hemangioma. So we have different patterns like focal, multifocal, segmental, or indeterminated. And we have different types like superficial, deep, mixed, radicular, and other ones. And there are some syndromes that we can see, some hemangiomas linked with other disease, like the most important, the face syndrome. There is a posterior fossa malformations, hemangiomas, arterial anomalies, and cardiovascular anomalies, and others. Okay, so it's really important to understand, but there is so many other classifications that can be used. There is no wrong, there is just a different classification. So we can see some examples from, I don't know why it's not so good here, but anyway, the different types of hemangiomas. And the most important is how to do the treatment. Most of hemangiomas, they will reduce with the time. So we can do an expectant treatment, but we have to check which kind of hemangioma we can do this expectant treatment. Cannot have anatomical compromise or a function impairment or any other complication as bleeding, ulceration, you know. So this kind of hemangiomas, we can wait months and even years that normally it will reduce. But some patients, we can start with some drugs that can help to reduce this tumor, these lesions. Okay, especially we can use those cases where there is anatomical distortion, partial compromise of orifice, exposed areas, and some repeated complication, as I said before, ulceration and bleeding. Okay, we can start to use some medications. And the surgical, first of all, is those one in an emergency situation. For example, extensive bleeding, or it's covering some area as eyes, nose, ear, okay, or when we have a pediculate tumor. Depends of kind of surgery, can do one kind of tumor, how it presents clinically speaking, and then we can decide which technique we will use. About drugs, nowadays the most important drugs that it's having very good results is the propranolol that reduce in a very good way the hemangiomas. But also steroids and interferon can be used as well. Another really important thing in the children age, it's about the burn. It's the most important cause of death in children under 14 years old. So that's why it's so important to the pediatrician, GP doctors to understand how to deal and how to teach the parents and relatives to prevent this one. Burn and fires are the 5th most common cause accident and death in children and adults in the USA. So that's why it's really important, these things. The toddlers and children are more often burned by scalding and flames, sometimes even during the bath. Okay, the most important actually. Most of children aged 4 and under who are hospitalized for burn-related injuries suffer from scald burns, 65%, or contact burn, around 20%. Hot tap water burns cause more death and hospitalization than burn for any other hot liquids. So that's why it's so important to teach, to explain how important it is to be careful during give a bath in the kid. Nearly 75% of all scalding burns in children are preventable. So that's why it's the importance of this approach from us as a doctors to the parents and relatives is so important. But of course, different age, different kind of accidents. So under 5 years old, for flame, we have to be careful about match, cigarette, fires in fireplace, barbecue pits, and trash fires as well. And from scald, kitchen injuries, so that's why it's important to not have kids in the kitchen, bathtub scalds as well, so, and some child abuse, okay? Greatest number of pediatric burn patients are infants and toddlers, younger than 3 years old of age, burned by scalding liquids. Again, it's important to explain to the parents. 5 to 10, the kids are growing up already, so we have to be careful, especially with the boys, because the boys start to be more, according to the behavior, of course, more active, and for flame, they want to play, they want to create these things, so we have to be careful. But for female, it's more common scalds, so that's why it's so important the kids in the kitchen must be unsupervised. Okay. And adolescents and men, of course, there is those gatherings between boys, and they can create some activities involving gasoline and some flammable products as a firework. Okay, electrical also for those adolescents that wants to climb some area or they want to change something, they want to play with something, so it can cause. So the electrical is very dangerous as well in these ages. So also, of course, we have so many protocols to treat like ACLS, ATLS, and we have the ABLS as well. And if you want to download, you can use this QR code because it is important to know how to deal with the patient, especially in the emergency. And according to the ABLS protocol, a guideline, okay, we have to understand, can you zoom in again? About the surface area, total burn surface area. And using this diagram, we can define the percentage of burn area. Okay, so it's, of course, there is other ways to calculate as the hand, the palm of the hand, we can use as 1% at least to have a approximately percentage of burn area. And then we can use the Parkland formula to calculate the hydration of the patient. So to maintain the hydration, it's really important after burn. And we have to consider only second and third degree to calculate the burn surface area. We don't need to use first degree, okay? We need to prevent to not reach this kind of situation where a young girl had this kind of burn, and after a treatment, after some skin graft, she reached this one, but it's not comfortable at all. Speaking now about static, okay, let's stop a little bit about disease. But it's important for the kids as well, because sometimes some disease, some things are related with self-esteem, okay? So the self-esteem is something really important during these years. Okay, so the first one is the prominent years, okay, that it's really common deformity, but there is no any associated functional deficit. But there is a lot of psychosocial impact. So the patient suffer a lot during the school, you know, so can suffer some bullying. And we can deal with this. But we have to understand something about the ears. It's because it's the first part of our body that reach the adult size. That's why we can see young kids at 6 or 7 years old that they have big ears, very prominent, and they suffer a lot in the school. Okay? So also, it's possible to know if the child will have a prominent ear since that the children is in newborn. We can at least imagine if it will happen. Okay? And as I said, prominent ears are one of the main targets of the bullying. And in my opinion, the most important way to treat the prominent ears is surgical. There is some non-surgical options that I will speak about, but that the one that really works, in my personal opinion, is the surgical treatment. We can start to do the surgery in the age after 6 years old. Why? Because in this time, the patient is suffering some psychosocial impact, as I said before. So we can try to deal with his self-esteem since 6 years old, even younger than like 5 years old. But of course, it's better to wait the cartilage be totally okay to promote the surgery. Anatomically speaking, the change that we can see in the prominent ears are, there's now how to point, no, okay, is the increased ellipse mastoid angles that we can see in the A photo, okay. After that, we can see an antihelical hypoplasia, so the patient doesn't have the antihelix well formed. And also can have a hyperplasia of the cavum with a protruding node. So in the most of cases, we have an association of these three anatomical changes. And during the surgery, we have to fix these anatomical changes. I say that I will not speak about surgical techniques, but it's just to understand that we can mold the cartilage to reduce the angle and to reduce the distance from the conchal and the mastoid.
Doctor, 3 minutes, please.
Okay, I'm almost done. So some case. The non-surgical option is, there is one device that can be used, but it's important to understand that needs to be started very early, in the first 3 weeks from the birth. Okay, why? Because the cartilage is still soft due to the maternal hormone. Okay, we have to apply this device and keep this device for at least 2 weeks to 4 weeks and see the result. But we have to be careful to not cause some damage like ulcer in the skin. Another important case is the gynecomasty, that is the enlargement of breast in men. Okay, that has so many causes like liver disease, kidney disease, but also it can cause by the imbalance of hormones or obesity. So it's very common to have a gynecomasty by this. The classification, we have to deal with the skin, the amount of fat, and the size of gland. So we have different classification, different types of gynecomasty, and the treatment must be according the surgery. There is some non-surgical treatment for those one who have gynecomastia due hormones, to use some drugs to block the hormones, or we have the surgical treatments that depends according to the classification. So just to understand some case here. Sometimes we have to do a liposuction to remove the fat when the patient has. We have to remove the gland excess, or in very extreme case, we have to remove the excess of skin, like this patient's 14 years old patient, that he had diabetes insipidus, and then he had a gynecomasty. Also, in some, we saw the boys, and now we can see the girls. There is one kind of breast hypertrophy in the adolescents that we can treat as an adult. We have to focus about the self-esteem, because most of these patients also, they suffer bullying in the school. So the treatment is not only thinking about the aesthetic, it's thinking about the psychological impact, okay? So we have to treat as an adult, the same technique, but focus on the psychological approach, okay? So thank you. Obrigado. Questions? No questions?
Thank you, doctor, for your brilliant presentation. We have one question. One question.
Okay. Okay, bye-bye.
What's the approximated age that we can refer some patients for you? For example, hemangioma, surgery, or for pregnancy year?
Okay, so since the born, since the patient is born, of course, it's better to follow this patient, because we can understand, first of all, if we are speaking about hemangioma, which kind of hemangioma, if it's bringing some problem like vision impairment or mouth or nose, that we need something fast. So the best option is to see immediately as the diagnosis.
I have another question, Lisa. Thank you. Burns hypertrophic scares, can they be prevented when to refer children for scar removal? Does it help to remove hypertrophic scare? I don't understand that.
It's about hypertrophic scar.
After, yeah.
Okay.
Burns, hypertrophic scared.
Of course, we have to understand about the healing process. The healing process of a scar takes around 2 years, okay? So it's better to treat, to deal with this. If it already has established hypertrophic scar, it's better to wait around 1 to 2 years to do a scar revision. But if the patient has this or keloids or hypertrophic scar, not very early, like immediately after, like let's say 3 weeks, 4 weeks after the suture, we can treat with some drugs or some injections to reduce the hypertrophic scar or keloids. One more question. Doctor.
Thank you, Dr. Paolo, for this very interesting presentation. I appreciate that. I have a little question. When is it safe or reasonably to put a constructive device in a child or in an infant? What's how safe it is to start reconstructive procedures in an infant? Let's put it this way.
Depends the kind of problem. For example, in the cleft lip, cleft palate, we can start the treatment after 6 months old. Why? Because the patient will be like, how can I say, more stable, it grows a little bit, so it's to deal with, because there is no emergence speaking about cleft lip and cleft palate. Okay, but if we are speaking about one hemangioma that is closing the eyes, we need to do as an emergency surgery, so we can do
the other question is from my specialty, gastroenterology. Occasionally, it's just occasionally, I see children coming to me with some kind of sexual abuse, and these children are left alone to heal. Do they really have to pass by a plastic surgeon?
Yes, they should. They should be evaluated by a plastic surgeon because we need to remind about the psycho impact in the patient. So this one, it can help these patients after abuse, you know.
Thank you.
It's really important.
Thank you very much, Dr. Paolo. A quick question, huh? لأن we already one quick question, Dr. Hassan, huh? And a quick answer, huh?
I didn't think that in the pediatric.
We are more interested now.
I should have so many.
Thank you very much, Dr. Paolo, for very clear presentation. My questions, before the question, I remember very well when I was doing my intern, that very long time ago, I was, most of the surgeries which you already described has being done by pediatric surgeon at that time. And I remember we had like one of the new plastic surgeon came at that time when we were doing our intern, and there always a lot of arguments with the pediatric surgeon because they consider them they're doing something just functional, not cosmetic. So I think in the team which you have mentioned, the pediatric surgeon has a role because now the expectation is different because regarding the plastic surgery, not regaining the function, they want even the shape and cosmetology part to be more effective as they expected. So in which way you can see the collaborations and multidisciplinary team, including pediatric surgeon, especially in pediatrics, with a plastic surgeon?
Great. It's a very good question because, in my opinion, always we need this kind of collaboration. You know, we have to work together all the time, especially in, for example, if we're speaking about omphalocele. Okay, so we need someone like training as a pediatric surgeon to help us, or even we will be there to help them. because I'm sure that they know how to close a omphalocellus. But of course, if I know the techniques or how to improve the statical part as well, we can work together. Okay, so all the time, not here in Bahrain, but in Brazil, for example, we was working together when we have some case like this, or with a pediatric surgeon, or for example, a head and neck surgeon, or a breast surgeon. So it's really important to work as a team. You know, there is no competition. There is only, we have to work together to the patient. Our main target is the patient.
Thank you very much, Dr. Paolo. Great presentation. Our next speaker is Dr. Najla Al-Jassas. She is a pediatric endocrinologist from our beloved Kingdom of Saudi Arabia. She did her study at King Abdulaziz University, did her Saudi board and Arab board, and then her fellowship in 2005 from McMaster University. She will be talking about common pediatric endocrine emergencies. Is Dr. Najla with us?
Yes, I'm with you, but I want to share the screen.
Yeah, hello,
please.
Doctor.
Good morning.
Take the floor, please.
Morning. Okay, thank you. I would like just to share my screen, please. Bismillah ar-Rahman ar-Rahim. My voice is clear? Yeah. Assalamu alaikum. Good morning, everybody. Good morning, ladies and gentlemen. Thank you for the organizing committee, actually, to invite me to this great conference. And I really enjoyed the speaker sessions today. Thank you very much. So when I was asked to prepare this topic, actually, I found it very difficult for pediatrician and for me to make it short in 25 minutes, but I will do my best to give you the common and the approaches, then followed by the references if you like to go back. Actually, and always really I like to present it for general pediatrician about this very key topic, and then we can deal with the extreme of the subspecialty cases. My content today will be I will go through introduction, the common endocrine emergencies, including hypoglycemia in diabetic. I know the DKA is a separate, so it will be afternoon this session today, as it needs really a lot of time to be taken for that key topic. So I will tackle first the hypoglycemia in diabetic, non-diabetic, and then adrenal insufficiency, diabetes insipidus. Then from the thyroid, I will take thyrotoxicosis and thyrotoxicosis storm, actually, congenital hypothyroid, acute hypocalcemia, and pheochromocytoma. This is what I did select for you to go briefly through today. Why endocrine emergency or endocrine diseases are very important for general pediatrician to go through. What we found throughout this, it's commonly to present with non-specific symptoms and signs, and it can mimic many. Can mimic GI, can mimic neurology complaint. It has very vague symptoms till you have diagnosis. And it needs a high index of suspicion to be diagnosed and treated promptly. Why? If untreated, as I said, hypoglycemia, if untreated, patient will go to catastrophic neurological complication. Patient diabetes, if missed, he will present with severe DKA. Patient with adrenal insufficiency, if not given hydrocortisone promptly, when it was suspected, patient can go to adrenal crisis and collapse if untreated. That's why very important to know the key of endocrine diseases and how to deal with endocrine emergencies. The endocrine system actually is a huge, the big boss is the hypothalamic pituitary axis, then it will go through the rest of the system. So I will go through, if we shall eventually, when I will talk about the pituitary, I will go through adrenal insufficiency secondary and primary from the adrenal part. Then after that, we'll go through the thyroid. Then we'll go from the hypothalamus and pituitary. Also, I will tackle through diabetes insipidus. Then we will go to hypopituitarism. After that, I will go through hypocalcemia. and hypoglycemia. I will start with the case just to make it a bit stormy. It's a clear and straightforward case, and we are called for a 5-year-old child, non-diabetic, and so no more information given that only his sugar is 2.9 millimole per liter. Then we will go through the first step. This is common scenario would you see in pediatric ward clinic and pediatric ER. First to know, we have to know the hypoglycemia symptoms that the patient present, and we know that usually either actually a patient could be asymptomatic and detected the level by regular check, or symptomatic minor symptoms or severe symptoms informed that he needs assistance. He cannot do by himself anything. He's drowsy or fainted or seizing. This is the most extreme we have. So we have to classify our patient, symptomatic, asymptomatic, or severe, informed that he has neurological signs. Second step will be the treatment. The treatment will depend actually on the classification we have. Asymptomatic or minor symptoms, we will give oral juice simply, 15-gram carb and 15-minute urea check. If the patient unable to take orally, you have to go for IV access, of course. If no IV access, you will have glucagon. And this is what I told always the mother at home. We give them the supply to have a glucagon at home so they can use it in case the patient is unable to take orally. This is very important, but that's why we need to classify our patient. We have clearly something called rule of 15 in management those patients, which is to give 15-gram carb if the sugar is below 70 milligram per deciliter, or we give half cup of juice or soda pop. Then we have to, in 15-minute recheck. Once we reach a target above 70, this is the time we give complex carb and protein meal to prevent further hypoglycemia. Then we revisit the cause. We sit with the family after we treat to know why this patient got hypoglycemic. Missing dose, giving extra dose, exercise without taking care of the exercise need of more food, sick patient not eating well. So we have to know the etiology after we treat. And always I tell that you have to go through every 15-minute recheck till we reach 70. And sometimes they have to treat once, 2, 3 times with juice till they reach. And they have to avoid any complex carb to be given during hypoglycemic episode. We need really simple juice to be given, or honey, 1 tablespoon or maybe 2 cubes of sugar or 1 tablespoon of sugar in a water to be given. We need very simple sugar to be given during hypoglycemia. They have to avoid the complex carb or the chocolate during the attack. Only when the patient recover, this is the time they have to give him the complex carb routine to maintain him. The third step, as we mentioned, we have to know the cause of hypoglycemia. We do revisit the insulin regimen. We will review the patient how much and to educate them how much they know about hypoglycemia, what they did at home before they brought the patient to ER. Did they start management or not? And always we have to know, again, with concomitant diseases that could cause the diabetic hypoglycemic episode. If we have no issues with insulin regimen, with the diet, with everything is stable, and parents reported unexplained episode of hypoglycemia, and the patient outside the honeymoon period, which is first 6 months of diagnosis, this is the time we have to think and to make sure the patient doesn't have concomitant disease causing hypoglycemia, commonly like celiac disease or Addison disease. So this is a summary in just to how to treat in emergency situation. In severe hypoglycemic episode, unconscious child, more than 5 years of age, we always tell parents to give 1 milligram glucagon. They can give it easily subcutaneously. Sometimes really difficult to give IM at home, but subcutaneous because they used to when they give insulin is the same. So we do advise them to give this vial of glucagon. Then they bring the patient to the hospital. In less than 5 years to give 0.5. Once the patient in the hospital, the best will be to start IV access and to give the patient 10 ml per kg bolus, then given, followed by actually IV access. We never give a bolus without having a maintenance of D10 after that to maintain the patient and to prevent rebound hypoglycemia. This is in case of severe attacks. This is a just graph summary of the patient, how they present actually with, or they complain of glucose below 4 millimole or below 70 milligram per deciliter. It depends too much about that the patient, if he has any neuroglycopenia or not into the fall and when to treat. This is a diabetic for 2 years when unexplained episode of hypoglycemia, and parents really denied any. He began to be in the same schedule, then he started to be sick, losing weight. He's just having unexplained morning hypoglycemic attack. Then this is the patient has to be with hyperpigmentation on exam. This is a clue to have Addison disease, and he has to be investigated and treated for. We move on. Commonly the diabetes is the commonest, so we'll have the DK afternoon. We talk about briefly about diabetic hypoglycemia. Then I will move to pediatric hypoglycemia in non-diabetic, and I think like the doctor, our professor, Dr. Abdel Mu'in said today, he mentioned about hypoglycemia at the presentation of metabolic disease, so he facilitated a lot my talk this morning. And so pediatric hypoglycemia in non-diabetic children, the definition is different. As you said here, always in diabetic, we need them to be less than 70, we label them as hypoglycemia. In other ages, we move between 50 and 60 milligram per deciliter. It's different totally based on neonate, preterm, full term, below 60, and pediatric more than 2 years below the 60. While pediatric diabetic kids has to be our target always above 70. But those patients, when we defined again hypoglycemia below 60, always our target when we treat those patients to keep them safe above 70. The approach is huge. Actually, we have many causes for this hypoglycemia attacks. We have those patients, usually they can have something, we have to, when we see them, we have to have something called the critical sample. Why this critical sample? To check glucose, when the patient hypoglycemic, to take all labs for hypoglycemia causes, including endocrinopathy, as well as metabolic diseases. So first sample to be sent to the lab when the glucose below 60, before treating the hypoglycemia, to withdraw plasma glucose first, then to collect with it all the written electrolyte, lactate, ketone, C-peptide and insulin, ammonia, glucagon, urine ketone, reducing substance, organic acid. Sometimes we do add even acyl carnitine, plasma amino acid, we go extensive. Growth hormone, cortisol, all has to be added to the sample. Why? Because really we need to know during an attack what is the endocrine response and what is the metabolic response to that low glucose. For that, this is the ideal to go through, and we move on for the etiology. The treatment of this type of hypoglycemia patients, and those patients, as mentioned, always asymptomatic or symptomatic, as we said, and then if symptomatic, the patient able to take BO or not. But depends a lot on how much the patient can use the gut. So we do treat them if the patient able to take orally, no vomiting, we will start with oral. If not, we will go for IV, as I mentioned, D10, the ideal 2 to 4 ml per kg, followed by infusion always. Never we keep patient just on loading of bolus without maintaining him. And always measure sugar very closely, initially 30 minutes, then hourly, till we stabilize patient, then we move on. After we treat, usually, we do identify the cause based on history, exam, and critical sample. But really, if any patient presented with hypoglycemia, non-diabetic, and no etiology, critical sample has to be done. And this is the only way to know sometimes the etiology, most of the time. This is the phenotypic, actually, appearance of some of our patients with hypoglycemia who are non-diabetic. For example, you have this patient here. She has distended abdomen, she's short, rounded full cheeks. This patient with glycogen storage disease type 1. This baby has actually infant of diabetic mother, LGF. We know that infant of diabetic mother, they do have prone to hypoglycemia due to hyperinsulinism. This is iodine. For that's why sometimes the phenotypic appearance itself, it's a great clue to identify the cause and to help you toward the diagnosis. Other congenital causes, we have here Beckwith-Whitman syndrome, we have large tongue, ear creases here, omphalocele. This is always those patients, even without having hypoglycemia, with such feature, mandate us to check even if they are asymptomatic for hypoglycemia, because we know they are at high risk based on their condition they have. Another important phenotypic feature toward hypopituitarism is midline defect like cleft lip and palate. Sometimes it's associated with hypopituitarism, anatomical defect, absence corpus callosum. It will extend deeply the associated midline defect that usually mandate actually screening for growth hormone deficiency, cortisol deficiency, other all pituitary hormones, because just simply and they are prone to hypoglycemia due to hypopituitarism. Those patients with this defect, they have to be screened even if they are asymptomatic. Another clue phenotypic patient with septo-optic dysplasia, who have actually they have blindness, and then they have actually absent septum pellucidum in MRI. Those patients actually they are prone to hypopituitarism as well due to anatomical defect and developmental abnormality. Another key clue, neonatal cholestasis, and we have many cases reported to have been present with a neonatal cholestasis found to have hypopituitarism. And when we treat those patients with hormonal replacement therapy, cholestasis improves. So we have many phenotypic features that could give you a clue toward the etiology of hypoglycemia and what to investigate in those patients. Moving to another cause, important etiology, it could be also a common cause for hypoglycemia in non-diabetic, and it's adrenal insufficiency. And we know that adrenal gland, we call it the gland of life actually, just because of the cortisol. Cortisol is main hormone that we know that patient is, this is very important hormone for life and for continuity of life. For always I told them the adrenal gland is the gland of life. So the adrenal gland control, it depends on hypothalamic pituitary adrenal axis, and any defect in that axis will lead to hypoadrenalism. At hypothalamic level, for example, we have tertiary. If the patient has pituitary lesion or anatomical pituitary defect or supraciliary tumor or ciliary tumor, they will have ACTH deficiency. It will be secondary. If we have a lesion at adrenal level, we call it primary. And usually the primary is the more severe. This is the time here where the patient present with salt loss crisis in addition to hypoglycemia. Cortisol, as I mentioned, very important key hormone, and it's responsible for, it causes actually elevate, it control both sugar as well as myocardial contractility, cardiac output, and catecholamine repressors effect. So it's very important for catecholamine to work for that patient with refractory shock. We do think in adrenal insufficiency as additional factor, and we do investigate them because usually characteristic patient with cortisol deficiency, they are unresponsive to catecholamine when they are hypotensive. So unless they are replaced with cortisol. That's why very important to go through adrenal pathway. The common actually stimulant for this axis is hypoglycemia, hypotension, stress. It's the hormone of stress. For that patient who have adrenal axis defect and they have adrenal insufficiency, sometimes they go asymptomatic. Once they are when they are exposed to high fever, sepsis, trauma, or surgery, this is the time when they present with collapse or signs of adrenal crisis. For that, those patients with suspected to have adrenal insufficiency, the best is to be tackled early, investigated, be safe, put in hormonal replacement. Then they can have stress doses of those for hydrocortisone when they go to procedure or when they come sick. This is very important. The common finding, as I mentioned, usually the problem with many endocrine is, especially, for example, if I talk about adrenal, there was a nice article published longly in 2006 from an American Academy of Pediatric about that adrenal insufficiency is still a cause of morbidity and mortality, was the title. And they found there was a lag between the first visit to physician and patient with adrenal insufficiency, sometime around 1 to 2 years between the first symptoms and the diagnosis. Why? They do present with non-specific symptoms, and they do visit their doctor, and they decide based on the complaint they have. Sometimes they do have the GI because of vomiting. Sometimes they present to emergency with recurrent abdominal pain. Sometimes they have neuropsychiatric symptoms. So really, it's sometimes it goes undiagnosed unless the patient has the classic phenotypic feature that have, especially the secondary type or pituitary type, or the one who has been on a steroid for a while and withdrawn. Those patients, they don't have specific symptoms to alert sometimes the diagnosis. That's why it goes undiagnosed for a while. In physical exam, the primary adrenal insufficiency always a classic. You have hyperpigmentation, you have genital abnormality. Sometimes if the patient have ambiguity due to CH, like a large clitoris, fused labial effusion. In boys, they do have macrovenous or small testes. Sometimes early pubic hair due to high androgens. Usually primary adrenal, they are more severe and they do present early and they do have more clues. But for that, the phenotypic, when we see it, we do immediately. With the secondary, the pituitary and tertiary type of hypoadrenalism sometimes is the most difficult to treat. And we have a few patients who presented actually to us, there was a lag between the endocrine symptoms and the appearance of the sign of a brain tumor around 6 months. So initially they present only with polyuria, polydipsia, hypoglycemia, then they go when they go with visual or neurological complication. This is the time when they do neuroimaging, and the neuroimaging found to have supracellular tumor like germinoma or like craniopharyngioma. But really, sometimes it's the presentation of it endocrine. It could be the endocrine presentation of CNS tumor, only endocrine manifestation like hypoadrenalism, central hypothyroidism. It need to be tackled. And always when patient has one deficiency in the pituitary, we have to look for another etiology. We have to assess the whole pituitary function to ensure. Patient who has central hypothyroidism, so I have to make sure that the adrenal axis is good before I go for thyroxine. If thyroxine given in the patient with pituitary hypothyroidism, we usually what will happen, it with the thyroxine itself, because it's increased the metabolic rate, so it will increase the demand. It will let the patient go to crisis. Always patient with pituitary hormonal deficiency, we have to make sure about other hormone that to be work, especially the relation between thyroxine and adrenal or gland hormones and cortisol. Usually when we have central hypothyroidism, we will treat first with hydrocortisone. If the patient has adrenal insufficiency, after a few days, we add thyroxine for the sake to prevent adrenal crisis precipitated by thyroxine replacement therapy. Otherwise, if the cortisol is adequate, for sure, we can go for only the thyroxine treatment. So those are sometimes the clues. Another clues here in exam, ambiguous, we mentioned about the ambiguous genitalia. We said about, for example, like this, for instance, clitomegaly, fused labia, hyperpigmentation, and the extreme. You can have a very sick child with encephalopathy. We have just a patient who landed to the clinic with hyperpigmentation and fake symptoms, and you have the phenotypic patient with midline defect. So it's just variable between causes. Initial lab to be done is the vital lab that done immediately and help you, electrolyte and glucose. We have to make sure that the patient has no hyponatremia, hyperkalemia, acidosis, hypoglycemia, which is the lab manifestation of a primary adrenal gland failure. Serum cortisol, ACTH, always do the combined. When you think when you think to assess the gland completely, do both. the hormone, the substrate itself, and the controller. For example, thyroid, I will do TSH3, T4. Cortisol, I will do cortisol, ACTHY, because really you will know the axis. In case of a primary, for example, adrenal insufficiency, you will have high ACTH, low cortisol. In case of secondary, you will have normal or low ACTH and low cortisol, and you will not have salt loss manifestation. Many initial labs will give you a clue toward your diagnosis. In case of commonly we have CAH, very common in our country, and it's part of our newborn screening program. We do 17-hydroxyprogesterone to detect early boys with 17 or with 21 hydroxylase deficiency. If CH suspected, 17-hydroxyprogesterone has to be done, urine sodium, potassium, and creatinine. And this is the pathway when you suspect if the patient is hypotensive, treat with hypotension. Altered mental status, of course, check glucose. In addition to hypotension treatment, you will add D10 if the patient hypoglycemic.
Dr. Angela, 2 to 3 minutes max.
Oh, طيب تمام. I wish more, يعني, if you give me, thank you. Hyperkalemic, if the patient has hyperkalemia. Then the key is the hormonal, the stress hormone hydrocortisone replacement therapy during sickness. You will give the patient action plan to have his doses, to have treatment during stress. And what are the stress hormone dose you have? Because it's very critical to give him the timely, the medicine. We give it by age initially, then you calculate. So below 3 years of age, give around 25 milligram, 3 to 10 years, give 50, and above 10 years, give empirically 100 for adrenal crisis. Don't waste your time to think about weight, dose, and so on. Just empirically based on age, then you sit and calculate, because it's very vital medicine. And this is to be given as action plan to patients as well. This is what we talk about iatrogenic coughing patient when they have adrenal insufficiency due to excessive steroid therapy. So again, we have to be careful about, we have a general pediatrician about the steroid replacement, about steroid treatment, topical, inhaler, systemic. If the patient develops signs, to avoid, just to as much as we can to give him a minimum dose patient has, just to avoid iatrogenic Cushing, and the patient will have adrenal insufficiency iatrogenic. This is very commonly, we do see it even by topical, sometimes due to extensive diaper treatment and so on. So very important to review our iatrogenic steroid treatment. The others, if I can go through just quickly, this is a DR hypopituitarism. If we, as I mentioned, we talk about anterior, the posterior part will be the diabetes insipidus. Always just, I want to say the key that if you suspect pituitary hormone deficiency, if you have one hormone deficient, search for another. That is very important. Always look about the phenotypic feature that give you a clue, and have high index of suspicion and screen before the patient goes symptomatic, or even refer to endocrinologist early if you have suspicion to screen, because sometimes they do need stimulation test and long journey to follow. So basically, based on suspicion, you are justified. Sometimes they do send to us referral. This patient have, for example, complete midline defect. Please screen him for pituitary function clearly. And we have the thyroid emergency. There is no time to go through, I know, but we have thyroid storm, and we have the congenital hypothyroidism. Congenital hypothyroidism commonly seen, and I consider it as an emergency, just for, we know that if it's congenital hypothyroidism, it's a preventable cause of mental retardation if treated early within the first 2 weeks of life. For that, we need to be tackled as emergency, to have the newborn screening program, to have the thyroid function test readily, to start treatment early within the first 1 to 2 weeks and not delay more than that. Even if you don't have endocrinologist, we can communicate by phone. If you have, till you refer, we don't need to wait for thyroid scan. We don't need for to have any delay. Those patients, the earlier we treat, the better the outcome in terms of mentality and learning ability. So I consider it as emergency just for the narrow window that we have to start the treatment and follow patients. Acute hypocalcemia is another important common presentation, and usually it affects both neuronal conductivity as well as cardiac conduction. So patient will present with laryngospasm, with tetany, sometimes with a prolonged QT interval. So for that, those patients who present with cardiac or neurological manifestation, they have to be treated with IV calcium and to be investigated. Always the sample of hypocalcemia to diagnose, you need to check parathyroid hormone, you need to check vitamin D level, you will take phosphate, magnesium, renal function, all take it at the time of low calcium. So at least you know the BTH level and so on. This is the pathway for the acute management.
Dr.
Maybe
Najla,
I'm stop.
you rapid.
Yes.
Sorry for that.
Yeah. Yeah. A bit late? Yeah.
Could you conclude, please? Yes.
Okay, sure. I will.
Sorry for
conclude.
that.
That's okay, sure. Anyway, thank you very much. I know it's lengthy, I could not take it in time. So basically what we had this afternoon, this is a summary for table of endocrine emergencies, hypoglycemia, adrenal insufficiency, hypocalcemia, if I will. Those are the common three for general pediatrician and need to be detailed needed. And always have high-end refer early and my references. So hopefully it will help us. I cannot cover it. Thank you very much.
Thank you very much, Dr. Najla. Sorry, we are out of time, but please, there are a couple of questions. If you can answer them online, if you can see them. One about isolate.
Yeah.
If you can answer them in writing to the people who send the questions. Sorry, we are off time now. Thank you very much, Dr. Najla. Appreciate it.
Thank you. So we have first question, isolated diffuse labia are common finding. You want me to write it for them better?
If you can answer within a minute, that's okay. Otherwise, if you can just post it on the Q&A section.
Okay, as you like. So basically, maybe I will go just will not be late. Isolated diffuse labia because common finding for general pediatrician to see. There is no need for endocrine investigation, and really estrogen is the treatment. The question, what is the role of topical estrogen? Topical estrogen, it will help a lot in making the area less dry and really open the and it's high, almost more than 90% effective. This is the first treatment for sure for isolated diffuse labia, topical steroid for 2 weeks course. That's it. The second question is they said about.
I'll have to stop you, Dr. Najla. Sorry, we have to go to the next speaker because we are over time. But you can write the answer in the Q&A section, please.
I will now. Thank you very much. Thank you.
Thanks a lot, Dr. Najla. Appreciate it. Have a good day.
Thank you.
Thank you, doctor. Now, Dr. Shaili Sati. Dr. Shaili is a specialist in dermatologist, graduating from KMC, Manipal, India, with over 9 years of experience in Bahrain, practicing both in general dermatology and aesthetic medicine, currently working in the hospital, Royal Hospital for Women and Children. Thank you, doctor.
Thank you, Dr. Marcella. I thank the team members of this conference for having me here. Also, Dr. Sohail for facilitating it. I'll be talking about the common skin problems in children. Yeah, broadly we can classify these skin diseases as rashes or infections, so infectious or non-infectious conditions. Among the rashes, most common ones are dermatitis. It could be contact dermatitis, allergic dermatitis, atopic, pityriasis alba, seborrheic dermatitis, and psoriasis. I will be going through each of this briefly. Infections, it could be a bacterial, viral, fungal infection or infestations with lice, scabies. So coming to eczema, among the skin problems that pediatricians see, I think there are 30% is skin conditions, and among the 30%, 10% is atopic dermatitis, commonly called as eczema. It starts in infancy, maybe around 3 to 6 months. Before 2 years of age, 80% of eczema is diagnosed, and the rest are diagnosed before 4 or 5 years of age. We need to know about the triad, that is atopy. Eczema is also associated with asthma and allergic rhinitis. Among infants, it is commonly noticed on the face, on the scalp, on the extensors, and as the child grows, it becomes more flexural. Neck creases are involved, and in adults, we see it commonly as lichenified lesions because it's been there for a long time. The skin becomes thicker, and it's seen on the hands and flexures, head and neck area. Sometimes if a child comes in for some other condition and you don't see their skin completely, they are wearing a full sleeve dress or shirt, there are certain things that you can see. When you see the face, if you see there is an infraorbital crease, which is called the Denny-Morgan's lines, then you have to look for atopy in that child. When you shake their hands, if the hands feel a little bit more rough, then you have to look for hyperlinear creases in the palms. Try and see other areas. If the flexures are involved, then yes, we have to address atopic dermatitis. There are many diagnostic criteria available. The common one is, the easier one is UK diagnostic criteria, where the most important, the first point is an itchy skin condition, and then there is +3 of one of these 5 points, that is, it has to be diagnosed before 2 years of age, a history of skin crease involvement, general dry skin, one of the relatives or the mother, father has eczema, siblings have eczema, or when you see there is flexural dermatitis. So one of the three of these points plus itchy skin condition can be used as a clinical diagnostic criteria. Now, eczema complications that has to be early, like you need to diagnose it early and treat it promptly because it can cause systemic complications. What happens in eczema or atopy is that the skin barrier function is lost, so the immunity of the skin is low. So any infection can be a little bit more severe, like herpes simplex infection generally, which is seen around the mouth, can be more disseminated. It can be more of ulcerated lesions. So you need to, the diagnosis, it's not the typical rash that you see. So you need to diagnose it earlier. Staphylococcal infections like impetigo can be a little bit more widespread. Similar to eczema, herpeticum, and staph infections, think of even hand, foot, and mouth disease becoming more extensive. Now the treatment is, the first thing that has to be done is emollients, and more emollients. You have to advise the mother to use a lot of emollients, be very generous, at least 3 to 4 times a day. This is the only thing that can help the skin barrier. And first line treatment is corticosteroids. Judicious use of corticosteroids is very important. In the flexures, you need to use a low potency corticosteroid. In other severe conditions, high potency can be used, but high potency has to be used for 1 or maximum of 2 weeks. Second line, you have to, cortisone sparing creams can be given later on for maintenance, like calcineurin inhibitor creams. Antihistamines, there is again a debate, like it's controversial whether it controls the itching of atopic dermatitis. Antibiotics should not be given unless there is a proven infection, and in very severe conditions, immunomodulators are given. Dupilumab is the most new one and more promising. It has a very good safety profile. It is FDA approved in 2016. I think it's available here from 2018. Again, because most of the skin conditions are treated with topical corticosteroids, it's very important to know how much of the cream has to be used. A fingertip unit has to be used for 2 palm size area. Moving on to other conditions, pityriasis alba is again commonly seen in people who have dry skin. It's a benign condition. Most commonly, parents will be more anxious that it could be vitiligo. So how do you differentiate pityriasis alba from vitiligo? Pityriasis alba, the skin lesions, the border is not well defined. It is very gradual transition from normal to hypopigmented skin. There will be mild scaling, and under Wood's lamp examination, there is no fluorescence. You can see more lesions, but there won't be fluorescence. So this is a picture of vitiligo where the border is very clear. There is depigmentation, that is complete loss of skin color there. And under Wood's lamp, you can see it, there is fluorescence. So it, under blue light, it looks more white. So it's called chalky white appearance. Other conditions like psoriasis, I think most of them diagnose psoriasis because of the silvery scales. They have thick silvery scales. A proper red plaque with thick silvery scales, and 30 to 40% of the patients will present with nail pitting, another clue to the diagnosis. In children and infants, there are different types of psoriasis. Psoriasis vulgaris is the most common one, but in children, inverse psoriasis and gutted psoriasis are also seen. Treatment is with topical corticosteroids, calcipotriol, and extensive lesions, phototherapy can be done. And to talk about one of the clinical tests, it's called Auspitz sign. If these silvery scales are just peeled off, you see bleeding points. This is because the scales, there is hypertrophy of the skin, and the underlying skin is very thin, the capillaries are fragile, so when you peel the scales, you see bleeding points. Moving on to diaper dermatitis, commonly seen. Most of them are treated and it's easily treated, but we need to differentiate an irritant. Common one is irritant dermatitis, but we need to differentiate candida and seborrheic dermatitis. Also in the back of the mind, keep psoriasis as a differential diagnosis. So irritant ones will spare the skin fold. So the groin area is not involved. Generally it is the genitals, the lower abdomen, the sides of the thighs are involved. Skin can be somewhere from mild redness to peeling, weeping skin. In candida, what you see is the folds are involved. And there can be satellite lesions, lesions which are like the earth and the moon. You can have small lesions around in the periphery of the rash. There will be superficial pustules. So these are 3 pointers to differentiate it from irritant from candida. Allergic reactions are very less. It's not very common. Atopic dermatitis usually spares the diaper area. Seborrheic dermatitis can, again, this is also less common, but it can be seen as yellow greasy scales. Also, if the scalp has cradle cap or axilla is involved, then think of seborrheic dermatitis. Secondary bacterial infections can be there. Psoriasis, if the lesions are resistant to treatment, think of psoriasis. Seborrheic dermatitis, another condition which has a bimodal appearance. It starts in infancy, it is seen as cradle cap infections, and In adolescents, it is seen in the intertriginous areas. So cradle cap, easy to diagnose, thick scales, yellow greasy scales, it's stuck to the skin. But you have to differentiate it from the rash of atopic dermatitis. Atopic dermatitis, the scales are fine. It is not as thick as that seen in seborrheic dermatitis. And there is more erythema rather than scaling. Also think of Langerhans cell histiocytosis in the differential diagnosis. Similar picture but with petechiae or purpura, like small red dots are seen. Then we have to think of Langerhans cell histiocytosis. Seborrheic dermatitis in adolescents. It presents as scaling and redness on the scalp, nasolabial folds, eyebrows, easily treated with antifungals. Another yeast infection is Pityriasis versicolor, commonly seen on the chest and abdomen area as white hypopigmented spots. Clinically, for this condition, you need to stretch the skin. This is called a fluff test. When you stretch the skin, the scaling becomes more apparent. So it is easy to diagnose Pityriasis versicolor based on fluff test. Antifungals again will help with this. It can present with hyperpigmented or hypo. It could be like white color or darker color lesions. Widespread lesions you need to treat with oral antifungals. Now, yeast infection is not contagious. It is just that it is present in everyone, but because of the ideal environment, you get Pityriasis versicolor. But here, the ringworm infection is a fungal infection that is contagious. Starts like a pimple, grows in size, and then there is central clearing. So it forms like a ring, very easy to diagnose. But there are many other conditions which look like ringworm, but they are not ringworm. So ringworm, the characteristics are, it's a scaly lesion, there is scales, the borders are well defined, and there is central clearing. If there are multiple lesions, they will all coalesce to form scallops. It is unilateral. Unilateral I'm mentioning because psoriasis can sometimes look like ringworm infections, but psoriasis is bilateral, ringworm is unilateral, or it can be present in any part of the body. It spreads by direct contact and also through formites, occasionally from pets. So this lesion again looks like tinea, but it is not tinea because there is no well-defined border here. There is no scaling, it's more of crusting. Again, there is no central clearing, so it is not a ringworm infection. This is actually a picture of impetigo. Pityriasis rosea. Pityriasis rosea, the etiology is not very clear. Pityriasis rosea will look just like a ringworm infection. It starts like with a herald patch, that is called the mother patch, looks like a ringworm infection. You will treat the patient with antifungals, but within 1 to 2 weeks they will come back saying, we have a lot of other, it is spreading and the medicine is not working. So think of Pityriasis rosea. How do you diagnose Pityriasis rosea? It is like a ringworm. The first picture that is seen on the slide is the mother patch. So here, on the inner border of the ring, you can see there is scaling. It is called colorate scale or a hanging curtain scale. So if this is seen, then you have to think of Pityriasis rosea, and within 1 to 2 weeks, daughter patches are seen all over the body, and they are seen along the skin lines like a Christmas tree pattern. It's a very benign condition, but it takes a long time. It starts increasing, the number of lesions start increasing between 2 to 4 weeks, and then it comes down again in another 4 weeks. So the total duration of this condition is like 8 to 12 weeks. So it is more important to educate the patient that this is going to take a long time. It is benign, there won't be any problem, it doesn't leave any sequel, but it is going to take a long time. To mention among the differential diagnosis, granuloma annulare, here scaling is not seen. Another, not common, but if there is a history of travel, you need to think of Lyme's disease. Here the ring is more than 5 centimeters. Sometimes it reaches up to 30 centimeters. There is a central vesiculation or a central lesion, so it looks like a targetoid lesion, similar to erythema multiforme. Erythema multiforme lesions are 1 centimeter, but these are 5 to 30 centimeters. If you see something like this, history of travel, tick bite has to be taken, and serologic tests can be done to diagnose, and if it is treated early, we can prevent the late Lyme's disease complications. Moving on to viral skin infections, commonly seen by pediatricians, viral exanthems. I will just go through few points among these. Chickenpox, fluid-filled vesicles, small blisters are seen. It is described as dewdrops on rose petal. If it's a widespread infection, it's easy to diagnose, but sometimes only 3 or 4 vesicles may be seen in the initial stage, which may look like an insect bite reaction. So in such situations, the blister fluid can be scraped off and seen under the microscope for multinucleate giant cells. Roseola, so it starts with fever, and when the fever settles, you see the rash. It is similar to, the rash is similar to measles, but there is, around each rash there will be a halo, and mucous membrane is not involved. Scarlet fever, not viral, it is due to streptococcus. Starts with pharyngitis, and then you see a rash. Important signs in scarlet fever is in the soft palate you can see petechiae, which is called the Forschimer's sign, and the rash is usually not seen, it is felt, so it is called a sandpaper rash, and it's also more accentuated on the flexures. Infectious erythema infectiosum, 5th disease. It's the characteristic feature is slapped cheek appearance. The rash may wax and wane for 3 to 4 weeks. Measles, before the rash appears, you do see Koplik spots. They are grayish-white dots with erythema around it, seen adjacent to the first or the second lower molars. After 2 days, the rash begins, and when the rash starts, these spots will disappear. Rash of measles will start in the head and neck region, generally behind the ears, and then it spreads from the head and neck region to the trunk and then the legs. Same way, the rash also disappears in the same pattern. Hand, foot, and mouth disease involves, it could be vesicles, pustules, papules involving the oral cavity, hand, mouth, buttocks and genitals are also involved. Treatment is, it generally heals within 1 week to 10 days. Treatment is supportive. Another viral condition is Molluscum Contagiosum. This is common in toddlers. There will be history of sometimes in summer months when they go to swimming pools, because it spreads through contact, direct contact. So it is sometimes you'll see a cluster of cases. So the skin lesion is a pearly white papule, looks like a vesicle, but if you look very closely, there is a small dip at the center, which is called umbilication, like the belly button, like there is a small dip in the center of the lesion. Treatment is by destruction of the lesions, ablative treatment. We can use keratolytics. You can express the molluscum bodies from the lesion or use cryotherapy, electrocautery. Another viral skin problem is warts. The surface will be rough. There will be small dots on the surface. This is because of the thrombosed capillaries. It is, sometimes the diagnosis is difficult because it looks similar to con, looks similar to a callus. So the differentiating points, how you can differentiate a wart from a con is, the con, when you press it on, when you put pressure on the con, there will be pain. But in a wart, there is pain when you squeeze it from side to side. Cons are generally round and small, well-defined. Warts are cauliflower shapes, rough surface. Skin lines are not interrupted in a con, but in a wart, the skin lines are interrupted. And cons are usually seen in the pressure areas in the feet. Wart can be seen anywhere in the body. So this is a picture. On the left is a callus or a con. Con is more well-defined. This is a picture of a callus. On the right, you can see a picture of a wart. So on the right, you can see a little, like it looks like a cauliflower-like growth. There is black dots on it. If you can't see the black dots clearly, you need to scrape the lesion. It will be more clear. And the lines, the skin markings, if you can see, the skin markings are destroyed there. Where the wart is, there is no skin marking. But in the callus, the skin markings run through through and through.
Doctor, 3 minutes more.
Yeah, okay. So among the bacterial infections, I will only talk about impetigo. If you see a yellow honey-colored crusted skin lesion, generally it is impetigo. It can be bullous or non-bullous. Bullous, the blisters are very superficial, so you don't see blisters when the patient comes. Sometimes you can see superficial erosions, but you need to ask about whether there was a blister before it happened. And cause is Staphylococcus aureus and most commonly treated with mupirocin. Now moving on to infestations, I will be talking about two types of infestations. One is the head lice and scabies. Head lice, if you see nits or lice, it is lice infestation, but few points to be noted is the lice lays the eggs or the nits very close to the scalp. So if it is more than 1/4 inch of the scalp, that means maybe the lice is less in number or it has been treated. If there is no enough time to scan through the whole scalp, at least see the occipital area. It is called the Low's pit. It is an ideal environment for the lice infestation because of the density of hairs and the scalp, the warmth of this area. Sometimes children can present with secondary bacterial infection. Itching may be there, so you have to look for nits or lice. Parents sometimes become more anxious, like mothers are very anxious when they see nits, they don't like it, so they will sometimes overuse the treatment given. Permethrin, if it is given for 10 minutes and then to be repeated after 10 days, sometimes they use it every day. They use home remedies, some people put vinegar, baking soda, so sometimes the child will have irritant contact dermatitis. So it is important to tell the mother how to use the topical, and it may take 2 to 3 weeks for complete resolution. To be more, it is a tedious procedure. To remove the nits it is good if you remove the nits manually. So they can spend their time removing nits rather than doing more home remedies. In immunocompromised children, if there is a chronic heavy infestation, then you have to look for pallor and anemia. Scabies, not very common in Bahrain. But if there is a travel history, you have to ask history of 3 things. One is, it's a very itchy condition. As you see, they will keep scratching their arms and legs. There is nocturnal itching, that is, the itching becomes worse at night. And other family members may be treated for scabies or they may be having similar condition. So when these three points are positive, then look for the web spaces, finger web spaces. You can see Burroughs scaling, and if you scrape the lesion and see it under the microscope, sometimes you may see the scabies mite. So this was my last slide. These are my references. And a take home message would be, take your time to see the skin lesions. Generally, you ask history and then go in for examination, but when it comes to dermatology, you first see the skin lesion and then ask leading questions. It will be easier for diagnosis. Thank you.
Thank you, doctor. Thank you so much. Clear presentation. We have one question for you. Dupilumab, it's a better to provocative to start or for refractory cases in atopic dermatitis?
I didn't get you. Dupilumab?
Dupilumab, about dupilumab, is for refractory cases or refractory cases?
It is for?
Refractory cases or you start for proactivity? You use, is that your first option or you use on the other treatment didn't work?
It's the last option. It is not, it is where for refractory cases and resistant cases where itching is uncontrollable, the atopic dermatitis is almost covering the entire body, causing erythroderma, not responding to other treatments, then dupilumab is used. It is an immunological, so it can't be just like you can't consider it somewhere near the first line.
Okay, the other question is about antihistaminic to antihistaminic to atopic dermatitis. It's okay or not? Because sometimes, because the physiopathologists, sometimes you didn't use before moderate or severe cases. What do your opinion about this one, or the current about this one?
Atopic dermatitis is a chronic condition, so you can't keep giving antihistamine for a long time. During flare-ups or if the child's sleep is disturbed, then you can give sedative antihistamines. But the mainstay of treatment for atopic dermatitis is emollients. Emollients, skin barrier, maintaining the skin barrier function is very, very, very important. So if you use emollients properly, also you can use something called as the wet wrap technique. That is after like a warm bath, 10 minutes of warm bath, within 3 minutes time, emollients have to be applied to the entire body, and on the rashes you can use a moderate potent or a low potent corticosteroid. Then a wet dress is applied, wet pajamas are put, and then a dry one is put on top of the wet one, and the child is allowed to be like this for 2 to 3 hours. This works really well, but it is very difficult. It's tedious to do this. But if there is a flare-up, if you do this 2 times or 3 times in a day, they improve drastically.
Okay, doctor. Thank you so much.
Thank you.
Now, invited Dr. Issa Al-Saad, graduated from IGAR University, pediatrician and training fellowship in MACH University, consultant at Royal Hospital for Women and Children.
Would you please share the lecture?
Talk about skin rashes in neonatal.
Assalamu alaikum, good afternoon, almost good morning, good afternoon. Neonatal skin rashes and lesions are a very common complaint that the parents would bring their children. It's not moving. So I will be talking about different types of skin lesions that we see in the neonatal period. They are not all rashes, but some of them are birthmarks. Because I'm using the it's not working. I'm using the computer.
This one, either front or back.
Thank you very much. I was using the computer, but it wasn't working. So I'll go through some of the rashes and lesions quickly, just to give an idea. And So, yeah, okay, thank you. So this, but I don't see it here. I want to see it here so that I can read it. I don't see it here. Guys, it should be. Yeah, I am dumb when it comes to computers. This is the best that I can do. I'm a neonatologist pretending to be a dermatologist for this session. So this is our NICU unit at RHWC. So this is the first rash, very common rash. So erythematous macules, patches, each with the central papule, vesicle, or pustule. This is a common presentation, very common. It usually spares the palms and the soles. It's erythema toxicum, completely benign condition, usually seen by 24 to 48 hours, and usually go away in a week time. The vesicles usually contain eosinophils on the right stain, has no significance at all. So just reassurance. This is a condition that usually babies are born with. So this is a baby who has pustules, but you'll notice that there is no erythema around it. He's completely healthy baby. These pustules rupture and leave a hyperpigmented area with a little bit of scales. And this is more common in black, dark-skinned patients. It's called transient neonatal pustular melanosis, sometimes confused with staph infection, and treatment, antibiotics would be given, but really it's completely benign. Usually the hyperpigmentation would stay there for a few months. The pustules themselves would disappear within a few days. Right stain usually shows neutrophils, but no organism. This is a condition that I have never seen, but it's nice to see, to know about. This is pustules and vesicles on the palms and soles. It's extremely pruritic. Usually it is seen in the first few months, not at birth, but could be at birth. And this is called acropustulosis. Acro because it's on the extremities. And usually these pustules are tense and they would disappear within days. However, it's characterized by recurrences that happen every 2 to 4 weeks on the average. Because of the extreme itchiness, it's confused with scabies. And usually it should be tested and rule out scabies. Usually the management is more potent, strong topical steroids, and frequently treated for scabies as well. Usually it goes away in a couple of years. This is common as well, especially in the hot weather. These are erythematous papules, usually on the covered areas, and it might be more of vesicles without erythema on the exposed areas, although both could happen. And the level of erythema depends on this is because of obstruction of the sweat glands, and usually the erythema and the inflammatory process would be more evident the deeper the obstruction. So this is called miliaria, and this one is miliaria rubra. Usually the treatment is prevention. So you would like to have a good cool weather, try to avoid overdressing the babies, and if it is bothering the baby or the mom, mild steroid will do the trick. So this is another benign condition, resolves without issues. Erythematous papules and pustules mainly over the face and scalp. And some people would differentiate between neonatal acne and this condition, which is called neonatal cephalic pustulosis. So it's mainly in the head area. And usually it appears on the average between 2 and 3 weeks of life. It's thought to be related to overgrowth of a yeast and fungus called Malassezia furfur. and might be related to androgens as well. Comedones usually are not present, but some experts who differentiate it from neonatal acne, they would mention that comedones might be there. Because of the yeast overgrowth, when you manage it, usually watchful waiting is enough, but if it's bothersome, then topical ketoconazole antifungal or steroid can be used. However, if it's extensive or more refractory, then because of the androgen theory for causation, endocrine testing is required to rule out androgen problem. These, at the chin, if you see it in the picture on the left, this is melia. It is inclusion cysts that contain keratin. And usually they don't have any erythema. They are usually separate. They don't clump together or group together. And usually this goes away by itself in a few months. However, if it is more persistent or severe or unusual distribution, which is usually in the upper part of the body, then other conditions could be thought about, like epidermolysis bullosa, but usually they would have skin problem, fragility of the skin. These yellow papules on the right is a condition called sebaceous hyperplasia. Usually it's in the nose and face, and usually they group together. It's completely benign. It goes away in a few months, so we just need to assure the parents. Melia could be present on the palate, and it's called Epstein pearls, or in the gums and called bone nodules, and these rupture on their own in a few weeks and go away. Now this is a more serious condition. These are clusters of vesicles on erythematous base. This is a baby that might be sick, and we have to have special attention to. This could be herpes simplex infection. So these vesicles are usually grouped together, and they may progress to pustules. They might be erosions, crusts. Even bulli could form because they are grouped together. There are three types of herpes simplex, neonatal herpes simplex infection. Localized, which is usually SIM infection, skin, eyes, and mouth. CNS infection, encephalitis, meningoencephalitis, or disseminated involving multiple organs. Even in localized infection, systemic illness and CNS infection should be ruled out. So we have to investigate, number one. Number two, a treatment with IV acyclovir is urgent and shouldn't be delayed till the results of the investigations. So the take-home message for even localized neonatal, localized HSV, it should be manage IV acyclovir and rule out systemic illness. Differential diagnosis could be in the middle, incontinentia pigmenti. This is vesicles, usually at birth in a linear vesicular pattern. Usually these are females because this is X-linked dominant, so it's lethal to male babies before birth. But patients with XXL, XXY genotype could happen, and they should be investigated. Usually they have other complications: eye, hair, teeth, CNS, and these patients need to be investigated, followed by a dentist and an eye specialist, and the other CNS based on the symptomatology. A patient who has vesicles or pustules, especially if they are sick, infectious reasons should be ruled out. This could be bacterial, staph, strep, gram-negative, pseudomonas, listeria, fungus like candida. It could be spirochetes, syphilis, or other viruses. HSV is one of them. Herpes, cytomegalovirus, and varicella zoster are other two. This is another condition that's sometimes confused with herpes simplex. So this baby has reddish brown papules that later crust. Usually these rashes are more in the upper body, head and neck, and the extremities, and they may have hemorrhagic vesicopustules. This was mentioned by Dr. Asheli, Langerhans cell histiocytosis. The importance of this condition is that it could be isolated cutaneous disease, but also could be systemic illness, a malignancy. So these patients should be examined to rule out extracutaneous manifestations. And organs that might be involved are the bone, lymph nodes, liver, lungs, CNS. As Dr. Asheli mentioned, sometimes they present with refractory, unusual seborrheic dermatitis or diaper dermatitis. So, but the clue, if they are not responding, if there are petechiae or hemorrhagic crust, think about other diagnoses. One of them is LCH, and refer to your dermatologist. Usually, diagnosis made by biopsy and special stain. Oncology should be involved. Patients with cutaneous involvement have good outcome. Usually the rashes disappear in 3 to 4 months, but they need to be followed long-term to rule out systemic involvement. Okay, breather. And if you are looking for Fuduli, this is my shadow over there. This is in Muharraq. Whoever is interested, this is a nice place that I go frequently to. So now, okay, we'll continue. Unfortunately, it would be nice to be interactive, but the sitting doesn't allow that. So this is baby with the blue, purple marks or nodules. Test yourself and see how much you get right, if you'd like. So this is called blueberry muffin syndrome. It is a reflection of extramedullary erythropoiesis seen in 3 main categories: congenital infections, so which is the commonest. Number 2, tumors. We mentioned one. Leukemia cutis, another one. Neuroblastoma. Hematologic, especially hemolytic disease of the newborn, and hereditary spherocytosis. This is a baby who seems in pain, crying with diffuse erythema, sheet-like superficial skin desquamation. This is staphylococcal scalded skin syndrome. Usually the treatment is management of the fluids, the electrolytes, temperature, pain management, and IV anti-staph antibiotics. Some experts prefer clindamycin to reduce the production of the toxin. This is another case, generalized or profuse erythema, and there is a scaling. It could be other things, but in this case, it's congenital candidiasis. It can present with, have also papules, pustules, it's crusts, bulli, and this is a congenital candidiasis. So usually the management is IV antifungal medication, but patient with erythema, you have to rule out sepsis and staph and other infections as well. Usually the diaper area and the oral mucosa is spared. This is a patient with dull pink macule or a patch that we usually see in this area, in the back nape of the neck, in the superior eyelids. And this is called nevus simplex or angel kiss. I like angel kiss, salmon patch. Usually it goes away in a couple of years. It's completely benign. However, with straining or crying, it may become more prominent. So just we need to assure the parents. No syndromic association at all. Whereas this one is a darker red and larger than the salmon patch. And this is a different, this is a capillary malformation called port wine stain or nevus flammeus. It could be only solitary finding or could be associated with other syndromes and other complications. Important thing, if it involves the ophthalmic branch area of the trigeminal nerve, these are patients who may have eye problem, including glaucoma. So they need referral to ophthalmology. And be aware of the other syndromes that's associated with it. One of them is Sturge-Weber with CNS calcifications, seizures, and developmental delay. A Klippel-Trenaunay syndrome is the one with the lesion on the lower limbs, and usually hemihypertrophy plus venous malformations or vascular malformations. This is a patient with annular plaques with atrophic dusky centers. Usually it appears more commonly on the 2nd to 4th week, often scaly. You can see the periorbital accentuation. It's called raccoon eyes. This patient may present with bradycardia at birth due to heart block, and the diagnosis as neonatal lupus erythematosus. The baby doesn't have SLE, it's just transplacental transfer of autoantibodies in the mom who might be asymptomatic and never diagnosed with any disease. So she needs to be worked up for an autoimmune disease. And usually these lesions disappear by 6 months on the average. The management usually for the lesions, nothing but sun protection is warranted, sometimes topical steroids. The main issue is if there is complete heart block, then the management is pacing, which is lifelong. There is also take-home message. There is increased risk of having other babies in future pregnancies if there was one affected. So I coordinated with Dr. Asheli, but not with Dr. Paulo. So this is not, we don't call it strawberry hemangioma anymore. So thanks to Dr. Paulo, he mentioned that the terminology is different now. We should stick with superficial, with deep, not cavernous, and combined or mixed. It's the commonest benign vascular tumor. It's more common in white females and premature babies, especially. Usually it becomes apparent, maybe not at birth, usually not at birth, but usually by 1 month. It progresses rapidly, grows rapidly, especially between 1 and 3 months, and almost complete the growth by 5 months. This is important for the management because you don't want to miss this window for management. Involution starts by 1 year and almost complete by 4 years, and many of them don't involute completely. So the management, the approach nowadays is completely different than we were taught and we have been practicing. So these are small, cute looking infantile hemangiomas on the trunk. Should I go and count them or not? Well, there is a reason. I should count them because if there are 5 lesions or more, this would be associated more with visceral hemangiomas, especially hepatic hemangioma, which could be associated with other complications. One of them is congestive heart failure because of high output circulation, and it could be associated with severe hypothyroidism. Take-home message: patient with 5 or more infantile hemangiomas, do ultrasound of the abdomen, especially for the liver with Doppler, and monitor the thyroid function and watch for CHF. This is called beard hemangioma. What's the significance? Well, it's disfiguring. It needs to be treated early, but also a hemangioma in this area is associated with risk of airway hemangioma. So this patient may present with hoarseness, with stridor, with barking cough, sometimes confused with other diagnoses. So if we have a beard hemangioma, first of all, refer to specialist by 1 month at the latest, should be as early as possible. For management, first of all, with propranolol and ENT referral to look for evidence of airway hemangioma. This is life-threatening condition. Large hemangiomas, Dr. Paolo already mentioned, this is called segmental hemangioma. The big ones that have more significance, especially on all of them, but especially on the face and the lumbosacral and perineal area. And they have all the complications: faster growth, more ulceration, more disfigurement, but also it can be associated with other syndromes and structural anomalies. So these needs to be investigated properly, and they may be associated with organ malformation as well. So, in general, these high-risk segmental IH should be treated again early, by 1 month, the best, and usually the treatment for at least 12 months if you go with propranolol, which is the first-line treatment. Face syndrome was mentioned by Dr. Paolo. So these patients should have MRI and MRA of the head and neck, look at the coronaries, look at the brachiocephalic, do an echo because associated with cardiac problems. And obviously for the ones on the perineal area and on the lumbosacral area, they are also can be associated with lumbar syndrome, which has lower limb hemangiomas, lower part body hemangiomas, urogenital anomalies, myelopathy, bony abnormalities, anorectal malformations, renal anomalies. So they would need ultrasound of the abdomen, pelvis, probably MRI of the abdomen, and especially of the spine to rule out spina bifida spinal dysraphism. So this is the take-home message. These patients need more workup and early transfer or referral to the specialist. Perineal hemangioma may present as ulceration, bad diaper rash, or diaper dermatitis. So think about other diagnoses.
Doctor, 2 minutes.
So the high-risk IH, usually any hemangioma of more than 5 centimeters in the body or more than 2 centimeters on the head and face, and hemangiomas who are on these areas mentioned by Dr. Paolo. I didn't organize it with you. I did with Shaley. So the management usually is propranolol. Second line is oral corticosteroids. However, it seems that topical timolol or timolol maleate, which is non-selective beta blocker, locally for thin or superficial IH, some centers mention that they have good outcome, as good as propranolol, and without the side effects, or less side effects. Propranolol should be at least 6 months, preferably more than 1 year, 1 year or above. These are the clinical practice guidelines in pediatrics by the AAP. The rest is quick, inshallah. Almost done. So another breather and the same place. So this is absent skin, 75% on the scalp. This is called, and we see it every now and then, so it's not that rare. The delay is from this one, not from me. So this is aplasia cutis congenita. It could be isolated or associated with other syndromes or disorders like trisomy 13, cri du chat, maternal medications. Red flag if you have hair color sign, which is this darker tuft of hair around the lesion, or if it's midline and big, you may need to further investigate for spina bifida or other complications. This is yellow, orange, smooth, hairless patch. We see it every now and then, usually at birth. This is called nevus sebaceous. Most of the time, it's isolated. It gets rougher and more obvious in puberty, and it may need our plastic surgeon. Very low risk of basal cell carcinoma, very low risk, but however, this is why these patients would need intermittent interval, long-term follow-up. This is Mongolian spot, extensive congenital dermal melanocytosis. It's completely benign. Usually it goes away in a few years. However, if it is extensive, look for the patient. If the patient has failure to thrive or developmental delay, this could be associated with other diseases like gangliosidosis, Hurler syndrome, and other diseases. But overall, this is a benign. Sometimes it's confused as a bruise, and parents may thought that baby was hit during delivery or because of IV collection, because you can see it in other places. This is called cutis marmorata. It's benign, it goes away. It's due to vasomotor instability. However, if it is not disappearing long-term, think about other diagnoses, Down syndrome, Cornelia D. Lang, or homocystinuria. And I think I will finish 1 minute. This is the last one. Go, okay. So this is, you see erythema of over half of the body with contralateral whitening or blanching of the other side. And I didn't know that this is as common as 10% in babies, in term babies. It's usually, but because babies are covered, sometimes it's missed. It may last from 10 seconds to 20 minutes. It goes away, it's completely benign. There is nothing to worry about. It's usually thought that is a maturity of the hypothalamus that deals with the vascular tone. And Dr. Paolo talked about melanocytic nevi. Thank you very much. So I stuck there till the evening, till night. It was a full moon. Thank you very much for bearing it with me. Appreciate it. Thank you.
Thank you, doctor. No questions. Thank you for your brilliant presentation. Of course, Dr. Sohail can talk about something.
I have a comment rather than a question, Dr. Isa. This was an excellent session. I mean, between Dr. Shaley and you and Dr. Marcella and Dr. Paolo, we learned a lot about the skin, differentiating it from sensitivity to pediatric diseases to neonatal diseases of the skin. And we noticed that they are completely different between neonates and children and adolescent skin diseases. Thank you very much. You really differentiated and separated these diseases beautifully, the four of you. Thank you.
Thank you very much, Dr. Sohail. Appreciate it. Okay, thank you, our attendees. Thanks to our distinguished speakers. Really proud to come after you and to be with you during this session. We'll have a break, and obviously the audience on Zoom, we'll have a break till 1 o'clock, is it? Till 1 o'clock, yes. We'll be back at 1, inshallah. Thank you very much.